I have internet and a camera that works. For the moment. Yeah. Hopefully all will stay well.
You do look like you're more at home today.
I am. Oh, it was a nightmare yesterday, but anyway, apologies to everybody.
You handled it very well.
Well, good afternoon. It's 1 o'clock, so I think we can go ahead and get started. On behalf of my workshop co-chair in the Planning Committee, welcome to the third and final day of our workshop. This is a product of the Forum on Global Violence Prevention at the National Academies of Sciences, Engineering, and Medicine. We come here today with a shared goal of understanding and preventing violence in all communities, and we are committed to science and to respect for all, regardless of gender, race, religion, political party, or any other identifier. The forum aims to facilitate dialogue and exchange by bringing together experts from diverse areas of violence prevention. And we believe that these complicated, albeit sometimes difficult, conversations are what can move us forward in preventing violence and its secondary effects. Over the past few days, we've talked about fear violence at its most basic levels: biology, psychology, culture. Yesterday, we discussed individual and interpersonal ways to manage, reduce, and prevent fear of violence. And today's session will focus on the bigger layer, on community and institutional approaches to violence, to prevention of fear of violence. So the first part of the session today will focus on fear of violence across the lifespan, from child abuse to intimate partner violence to disability and elder abuse. And the second session will focus on threat management and resilience frameworks. And now I'll turn it over to my conference co-chair.
Thank you, Emmy. So our speakers for part one are Dr. Xinqi Dong, who is the inaugural Henry Rutgers Distinguished Professor of Population Health Sciences at Rutgers University and Director of the Institute for Health, Healthcare, and Aging Research. Dr. Kenya Fairley, who is Supervisory Family Violence Prevention Program Specialist at the U.S. Department of Health and Human Services. Dr. Virginia Duplessis, who is the Program Director of Future Without Violence. Nasser Young, who is a captain in the U.S. Army and a youth courts program leader at Chester High School. And Dr. Jerry Donnenberg, who is Professor of Medicine, Psychology, and Epidemiology and Biostatistics at the University of Illinois at Chicago. The session will be monitored by Dr. Stephanie Alexander, who is with the Office on Women's Health, Office Assistant Secretary for Health with the Department of Health and Human Services. The Office of Women's Health was established in 1991 within the U.S. Department of Health and Human Services. The office coordinates women's health efforts across Health and Human Services and addresses critical women's health issues by informing and advocating for policies, educating healthcare professionals and consumers, and supporting innovative programs. We are excited to learn from our speakers how fear of violence relates to their interventions, and also what their recommendations are for managing, reducing, and preventing fear of violence. So with that, I will turn it over to Dr. Dong.
Thank you very much, Corinne. It's great to be with our distinguished panel of guests, and thanks the National Academy of Medicine for hosting this important session. My background, I'm a geriatric physician by training. I'm a population epidemiologist, and I study not only issues of elder abuse, but the violence across the lifespan as well. And when I was thinking about what I was going to say today, because, you know, in about a number of years ago back, I had a privilege to chair the elder abuse workshop at the National Academy of Medicine, and a number of reports was published from that. And the field has really changed a bit since that time. I think substantial progress is being made. And I think the issues of looking at fear of violence is really a timely topic. But just to step back a bit, thinking about why is elder abuse unique, in the sense that, you know, when I give talks about the topic, I show a slide of, you know, when we think about the issues of child abuse, it elicits a very visceral reactions amongst us. When we think about issues of intimate partner violence, that the societal injustice, it really has gotten to a point where I think a lot of progress is being made with the Me Too movement and et cetera. But yeah, when we think about elder abuse, it somehow doesn't elicit that visceral reaction of injustice. And we're often asking ourselves why. We ask our colleagues, we ask our advocates and policymakers. I think in part is knowledge base, but also in part a lack of research, as well as the complexities of elder abuse. And when we think about the field of elder abuse, it's not just the issues of psychological, physical, and sexual abuse. But there are issues of neglect, issues of caregiver neglect, issues of self-neglect. And I'll come back to that in particular relevant to this topic, but also issues of financial exploitation that are often insidious, unknown. And yet when we think about the concept of fear, fear, as you know, it's as you talked about already, it's really a multidimensional construct that there are good and bad. You know, there's a spectrum. Some degree of fear may perhaps be a good thing. Too much fear can very much be a bad thing. Probably no different from any other construct out there, ranging from, you know, is too much social support a good thing? Is too little social support a good thing or a bad thing? I think there's really a spectrum, a zone where you look at where can understand issues relating to elder abuse. But before fear, needs to be a perception of threats. And we don't always think about that way, that in the field of elder abuse, not everyone perceives fear, you know, or not everybody able to perceive fear. In the issues of psychological, physical, sexual abuse, the intimate partner variance, I think you see that's very much common. But in the area of caregiver neglect, often it's much more difficult to articulate for someone who may experience that fear, who may even perceive anything as a threat. And understanding threat before fear is just as important as understanding fear itself. And when we think about, you know, what kind of threats are, you know, there are physical threats, there's psychological threat, there's social threats, there are economic threats, and many different threats out there before the least of the fear construct. And it's very much of a fight or flight response. And I'll come back down to talking about intervention and the path forward in a second. And so that's really critical for us to understand how does issues of things like caregiver neglect or self-neglect or financial exploitation, where the victim may or may not very much know that something has been done to them that are wrong in those ways. And if so, do they perceive a threat? Do they experience fear? And I think those are some of the nuanced issues we really have to understand more in the field of elder abuse that perhaps are different in other areas. And when we think about more particularly elder self-neglect, those are older adults who neglect themselves and put their health and safety into jeopardy, not necessarily with a perpetrator in place. In those cases, and issues of self-neglect accounts for substantial portions of cases reported to Elder Protector Services. And they're very uniquely different. And if you watch the A&E show, The Hoarders, that's one of the prototypical forms of self-neglect. There are other forms as well. But in those cases, some of them may very much experience fear, some of them may very well not to perceive what their behavior as a threat to their health, and not necessarily as something that they're experiencing fear for as well. And issues of dementia, people with a different spectrums, cognitive impairment, and also figuring out what are the accurate perception of fear, what are perhaps medical comorbidity that leads to the perceptions. For example, people with advanced dementia may have advanced neuropsychological psychiatric symptoms, delusions, paranoia, delirium, that often can give them a very fearful experience because they perceive something as threat to them, a shadow in the corner of the room that they perceive as a stranger in the house, and etc. How do we interpret those dynamics in the settings of elder abuse, neglect, and financial exploitation are also very unique that perhaps we have not thought as much about. Certainly very limited research in this area as well. How do we think about pathway forward? A lot of the work that we've been doing at Rutgers Institute for Health is really thinking about violence not necessarily attributable to an individual person, but understanding family levels. A paper we published last year in JAMA Internal Medicine looking at interconnectedness of child abuse, intimate partner violence, as well as elder abuse. Really, I think is important first step to highlight the importance of studying family units. When there's a fear in relation to one person, often there are fear within the family. Imagine if a victim who is elderly, who also caring for grandchildren, And they may jointly experience fear, and the shared feared experiences are something we really have not studied very much or understand very much about. It's really important to think about that as a point of a potential intervention pathway forward. A number of years go back when at the Global Violence Prevention Forum, Rahul Huseman talked about the concept of contagion of violence, really thinking about the violence as a virus, as a contagion that can really spread. Are we really capturing the fear of violence in that way? Thinking about not only the person who are the victim, but also that the families and the networks are involved in this way. The second pathway forward is really thinking about how do we study resilience. I know there's a panel down the line to think about that issue more deeply, but it's something that we have been thinking very deeply about and really conceptualizing resilience, not necessarily as just the opposite of risk factors, because I think they're uniquely different. When we think about resilience, we think about assets, attributes, and attitudes, and really understanding conceptual framework relating to resilience really will help us thinking about what works, what doesn't work, and how much resilience is a good thing, how much too much resilience may not be a good thing, and too little resilience likewise as well. And my last point before I pass on to my esteemed colleagues is really understanding culture norms and values. Because I think as much as we understand issues of elder abuse, intermarital violence, and child abuse, and other forms of violence as well, we must study culture norms and understanding cultural values. So what do I mean by that? Understanding what are the culture norms that defines a culture, for example, the issues we study in Chinese culture, the concept of filial piety, understanding the intergenerational relationships, understand the concept of la familia, for example, in Hispanic culture is incredibly important. Understanding the concept of hong in Korean cultures, how does it relate to intergenerational expectations and caregiving responsibilities, or something really antecedent to the occurrences of violence that we have to understand more of if we were to design broader interventions. And my last point is really pathway forward to really engage our aging networks and community partners. And I think this is where many of the AAAs, and I see colleagues of mine, Edwin Walker from ACL, AOA, who really pioneer many of the pathways in terms of thinking about elder justice issues. And I think those are models we really need to collaborate with our aging partners and networks. And because I think that's really important to create a interconnected network to be able to pave the way forward towards combating issues, not only elder abuse, but understanding fear of violence as a whole. So thank you. Corinne, you're on mute.
Okay, thank you so much, Dr. Dong. I think that Stephanie Alexander is with us, our moderator, and now we will turn it over to Dr. Kenya Fairley.
All right. Hello, everyone. Thank you so much for the opportunity to be here today to present to you all. I just wanted to make sure I was off mute. So I will be talking to you today about the work of the Family Violence Prevention and Services Act program, which is based in the U.S. Department of Health and Human Services and the Administration for Children and Families. I'm actually going to share my screen so you can see my slides come up. So please let me know in the chat if there are any issues with the slides, but hopefully you can all see those there. So within the Administration for Children and Families, the Family and Youth Services Bureau administers the Family Violence Prevention and Services Act program, which was first passed by Congress in 1984. So we've been doing this work to address domestic violence as a public health issue for over 35 years now. So for over the course of our 35-year history, FVPSA has ensured that dedicated federal resources are available to expand and support domestic violence shelters and supportive services, state and national training and technical assistance, as well as authorize and fund the National Domestic Violence Hotline and its special projects. So fear of violence is extremely relevant to our field of study and to the work that we do to address domestic violence, because as I'm sure many of you know, domestic violence perpetrators really rely upon a victim's fear of further harm to maintain their power and coercive control over those victims and their families. Perpetrators of violence employ a variety of tactics to demean, hurt, manipulate, and humiliate their victims. And that includes things such as overt acts of physical violence, emotional abuse, sexual violence, stalking, intimidation, threats to harm or take away a victim's children, threats to withhold or actually withholding financial support and resources, sabotaging their employment, sabotaging their credit, as well as gaslighting, among many other tactics, some of which the previous presenter talked about in terms of elder abuse and what that looks like. These tactics of abuse can really exacerbate the very real and rational fear that victims may have about the impact of victimization on their lives. And that includes the short and long-term health impacts, as well as their physical well-being, the potential that victims and their children may have to lose their home and their financial stability, the possibility of becoming engaged with various systems, such as being engaged in the shelter or homeless system, child welfare, family courts, TANF, and other public benefits, as well as the potential loss of custody of their children through legal battles, potential incarceration for defending themselves, and the potential loss of life when perpetrators become their most lethal. So there's a lot of fear that is very rational that victims of domestic violence experience and that they have to act upon in order to ensure their own safety and that of their children. So under the umbrella of the Department of Health and Human Services, the FVPSA program addresses domestic violence and those interrelated fears as a public health issue that necessitates that states and tribes have consistent funding to implement essential crisis response services to meet the safety and stability needs of approximately 1.3 million victims of domestic violence and their children each year that we serve. So we work in many ways to help manage and reduce and prevent the fear of violence by supporting community-driven solutions to address domestic violence and really working to promote partnerships amongst FVPSA-funded programs with other community-based agencies, services, and supports. You can see here on the slide that FVPSA supports over 1,600 local domestic violence shelters, programs, as well as tribal domestic violence programs that are seeking to address and prevent domestic violence. We fund a network of statewide and national training and technical assistance resource centers, and you'll see those here in a moment on this screen, that these are some of the national technical assistance providers that we fund that are doing work. And these programs, our local programs in our tribes, really rely upon these resource centers to build up their additional knowledge, to support continuous quality improvement efforts, to build capacity, as well as offer specialized services to abused parents and their children. So in addition, as I mentioned a moment ago, we also authorize the funding of the National Domestic Violence Hotline, which provides services 24 hours a day, 7 days a week, 365 days of the year. They also have two special projects such as Love is Respect, which promotes healthy dating relationships amongst youth, as well as Strong Hearts Native Helpline, which is a culturally appropriate resource for American Indians and Alaska Natives. So these community-based resources and supports that we offer, they're all free and they're anonymous. And we really seek to strive and promote victim confidentiality and privacy through the provision of these services. We have a number of well-trained advocates that really focus on keeping survivors at the center of their interventions. They provide emotional support, safety planning, education about healthy relationships, and direct connection or referral to other agencies within the community that can really support the needs and the unique needs of victims and their children based on their circumstances. So you can see that information there on the screen in front of you. So what I want to spend some time talking about in terms of how FVPSA works to address and remediate some of the fears that victims experience is we do a lot of systems engagement work, and we also work across the federal government to really help leverage the resources and supports that are available. So I'm going to talk a little bit about some of the programs that we support through our interagency partnerships. So one is Project Catalyst, and this is a partnership that we have with the Health Resources and Services Administration, Office of Women's Health, and their Bureau of Primary Health Care. And so this is a project that we have actually scaled up from. We've been working with them for quite a few years, and we initially started out with 10 cities and domestic violence programs, and then we have scaled that up to statewide leadership teams within a few specific states as well as a territory. And now we're looking to scale that work up to a national level. And what these state leadership teams do is they really focus in on policy and practice changes as it relates to HRSA-funded community health clinics, health centers, and their partnerships with domestic violence and sexual violence programs within the community. So they do work related to addressing the specific policies within their service area as well as within their state. And then they try to advance more trauma-informed practices as well as education about the health impact of domestic violence, sexual violence, and human trafficking, so that they can then facilitate warm bidirectional referrals for those that they may see coming into their programs. And so what we found, we're now in the third phase of Project Catalyst. And what we found in one of the first phases is that we trained over 600 healthcare providers, and 95% of them reported an increased understanding of how the education about the adverse health impacts of intimate partner violence and human trafficking can really improve patient care. And it could also help connect their patients with immediate crisis-oriented services in their community because of that bidirectional referral as well as the relationships that have been built through Project Catalyst. So we're really proud of that particular project. Another project that we have made great strides around is the Domestic Violence Housing Technical Assistance Consortium. As I talked about a moment ago, survivors can be really afraid of housing instability as a result of experiencing domestic violence, as well as other tactics that their abuser may use, such as things to destroy the property, to make it unsafe for them to live in a particular area, or just other things that really undermine a victim's financial independence and self-sufficiency. So through the Domestic Violence Housing Technical Assistance Consortium, we really look at the intersection of those issues. And this is a partnership that we have in place with HUD, with the Department of Justice and their Office on Violence Against Women, as well as the Office for Victims of Crime, and the U.S. Inter-Agency Council on Homelessness, where we all come together and we support technical assistance providers that can do research, they can develop resources, and they can really work in local communities to address the housing and homelessness issues that survivors of domestic violence and sexual violence face. And what's been really helpful is they've also, we've been doing this partnership for quite a few years now, about 5 or more years. And what they found early on is that it was really instrumental for the Domestic Violence Housing Consortium to be able to unpack some of the different federal statutory requirements and regulations that were in conflict with each other, that really created barriers for survivors to get the housing supports that they needed. So they've been able to really help identify some of those challenges that we can work on at the federal level, as well as help provide easier ways for programs that are serving housing, that are working to meet the housing and homelessness needs of individuals, as well as those that have experienced domestic or sexual violence. They can really help translate some of that federal regulatory, statutory language into understandable terms to help them really advance the work that they're doing. So this has been a great partnership, and we're continuing to also expand into areas where we're looking at what's happening with tribes and the housing needs across many tribal nations and communities. So that's been a really fruitful project. A couple of others that I want to talk about is primary prevention of domestic violence. So this is a partnership that we have with the CDC, and we've been working with them also for a number of years to really promote primary prevention of domestic violence, and to really bring together a lot of states and coalitions that are working on this issue to not only help build a case for primary prevention, but also to identify those primary prevention campaigns that are really helpful and instrumental, and that can be supportive of the efforts that are happening on a local level. And then we also most recently have done partnership with the Assistant Secretary for Planning and Evaluation, with the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. We've done some work related to unpacking the issue of substance use coercion. where perpetrators of abuse can really undermine a survivor's sobriety as well as their recovery from substance use disorder and other types of addictions. So we've been doing work to really understand what the substance use, how the impact of substance use coercion, how it affects victims' introduction to use of drugs, how it exploits their vulnerabilities, and as I said, how it can really interrupt any recovery or sobriety that they may have, and then how that interacts with other systems where survivors are really seeking services and supports. So we've been doing a lot of great work around understanding the research, what the literature says, trying to understand the various policies that may impact survivors, as well as promote greater practice changes. So more recently, as the COVID-19 public health emergency has continued to evolve, the tactics of people who use abuse has changed a bit to continue to elicit fear in victims, as well as to really exploit their vulnerabilities under this current pandemic. And so I wanted to provide a link to the this particular coercive control video that was developed by the Battered Women's Justice Project. And it's a really great video that explains some of the more COVID-specific tactics of abuse that have been happening. And I think as everyone on this session can understand, that being isolated at home with an abusive partner really increases the negative effect on victims of domestic violence and their children. It has great impacts to their mental and emotional well-being. It may disrupt any opportunities that they've had for respite from the abuse by going to work or daycare or childcare. It really impacts their ability as far as victims to really safely care for their children, homeschool their children if they need to, and for the children to really just function without that ongoing constant fear of harm. And it may also interfere with the victim's ability to work from home or maintain any other type of employment if they're essential workers or whatever the case may be. And so this can really undermine any stability and independence that they've been working towards, and really make it difficult for them to reach out to others who may be in a position to help them, because they again are being sheltering in place and being isolated with that abusive partner. So it's really important for us to think about the very unique circumstances that survivors may be in under this current pandemic in terms of our help to them. And I just want to touch on a couple more things before I get ready to close out. So when we think about building resilience, we also fund the specialized services to abused parents and their children demonstration sites. And so you can see a brief map here of the current sites that we're funding across the country. And then we also just recently closed out the competition to fund a new cohort of 26 grantees that will also be working to identify evidence-informed, practice-informed, culturally appropriate, trauma-informed, and age-appropriate interventions to use with children and youth exposed to domestic violence, as well as their abused parents together as a unit. So we're really excited about these programs because they focus in on developing and cultivating resiliency in those who have experienced abuse and violence, as well as working towards ways to help survivors thrive with their children together. And then when there are opportunities for a meaningful reconnection with the parent who may have used abuse, then also supporting the parenting efficacy to make that happen. So these are some of our greatest projects that, again, we really enjoy working with tribes, local communities, and with states on this very important work. And so I think with that, I'll just close out by saying that as I was talking about the COVID-19 impacts a moment ago, that I think what we're continuing to learn is that there are some innovations that have been really helpful for programs that I believe they're going to continue or expand as we continue to move through the recovery and response to the COVID-19 pandemic. And some of those things really relate to use of remote or digital services, text-based services, and a lot of them have found that they've been able to expand their reach in terms of working with victims who may be in more rural or geographically isolated areas, because they've been able to provide some of those non-traditional methods of providing mobile advocacy or meeting with survivors in places that are safe for them, and not always having them come directly to the office or to the shelter. So there are a number of different innovations that I think will continue. But with that, I will wrap up and I will pass it back to our moderator. Thank you.
Thank you so much, Kenya. Really appreciated that presentation. Our next speaker is Virginia Duplessis. She's a program director on the health team at Futures Without Violence, providing oversight for initiatives to strengthen partnerships between the healthcare and domestic violence services sector through improvements in clinical practice, organizational policies, and systems change. She brings over 20 years of experience in domestic violence, sexual assault, and public health in direct service and management roles. So let's please welcome Ms. Virginia Duplessis.
Great, thank you so much for having me today. See, I've already had some tech issues. There we go. So I think that Kenya made a great kind of opening segue for me to really talk about how we can think about addressing fear of intimate partner violence in healthcare settings. As mentioned, I'm with Futures Without Violence, working very closely with Kenya. We are the Health Resource Center and also provide the training and technical assistance for 2 of the projects that Kenya talked about. We also have very robust public education campaigns. We work with academic partners on research, and we do some policy advocacy, really to think about how we can address intimate partner violence, human trafficking, child trauma, both from a prevention and response framework, and really thinking about changing our systems. So let's talk about fear again and what survivors might be fearful of and how can we address that. First, I just want to acknowledge that today we're focusing a lot on survivors, and certainly people that cause harm are also experiencing fear, are motivated by fear. And I think that as a field, that's an area we really want to think about. You know, if we truly want to prevent violence, then obviously we need to be thinking about how to change the attitudes, behaviors, and circumstances of folks that cause harm. And then the other kind of big picture piece to really layer on top of this, which I think Kenya did a great job outlining, is in this moment of COVID, there are additional fears, both on the part of people that are experiencing violence, and again, you know, folks that cause harm use that fear to their advantage. So when we think about fear, I was really excited to be part of this panel because I thought about, like, okay, there's so many different layers, right? So when you think about that individual level, survivors fearing their partners, because there have been threats and violence, also really a lot of fear of systems involvement, which Kenya also mentioned. So worrying about if police get involved, child welfare, immigration, other kinds of systems that necessarily serve survivors well. And there's that saying, you know, it's the devil that you know versus the devil that you don't know. And oftentimes survivors are really trying to figure out, you know, with my partner, although they may be unpredictable, I have a better sense of what might happen if I am, you know, in this situation versus calling someone, you know, outside, calling the police or what have you. So really thinking about those decisions and the necessity to weigh those fears that survivors are really coping with every day. And then on more of a relationship and community level, remembering that there is still such a social stigma in talking about this issue. I think it's great that, you know, we have this session that specifically is talking about IPV. And for those of us kind of in the movement, this is an area that we feel really comfortable talking about and really understand the dynamics. But generally, in many communities, this is still something where folks that are experiencing violence are blamed and shamed, and you know, seeking help or leaving a relationship that might be unhealthy or unsafe comes with some negative consequences from friends, family, and community members. You know, there's so many times that the questions are asked, you know, why does someone stay in a relationship? Kind of, and then on the other side, people who are experiencing violence are expected to make relationships work. So from that social aspect, it's very hard to discern, you know, what's the right decision for me. So really thinking about that. And again, in terms of that systems level fear, I think we need to really acknowledge that we are often relying on systems that negatively impact marginalized communities. And I think that, you know, in the news recently, there's been a lot of talk about, you know, child protective services and policing and how those are systems that often increase harm. And certainly there is an aspect of fear there as well. All right, so that's a lot of bad news. Probably a lot of what I've just spoken of is not new information. It might be a different way of framing and thinking about it. But now let's really talk about what we can do to reduce those fears, address those fears, and build up some resilience. I know that later sessions are going to focus on resilience, but I think it's really important for all of our interventions, whether it's at that individual level, at more of a relationship level or the systems level, to really center healing and resilience, because we know that that is very motivating for a lot of folks. So a couple of different interventions on those levels. As a health resource center, as Kenya mentioned, we work a lot to build the capacity of providers, right? So what are those clinical interventions that can help reduce fear? Because oftentimes fear causes an immobility and inaction, right? So if we can reduce that fear, then oftentimes survivors are able to see new and different choices to help increase their safety. So one of the things that we really try to do is normalize accessing advocacy services. So making sure that patients, clients, participants in programs don't feel that reaching out for help is something that is negative or stigmatized, really talking about how reaching out to those services is a sign of strength and support. We also want to make sure that, you know, as we are talking about here, all these great programs in the community, how can I, as Kenya talked about, make those bi-directional referrals? We don't want folks to feel the need that they have to disclose what's happening in their relationship in order to access those resources. So for a long time in healthcare settings, we worked really hard to make sure that everyone was screened for domestic violence, right? So there's a list of questions. If someone answers yes, then you say, okay, here's a hotline number. I would posit to you that a screening alone, and we know from research, screening alone does not help to increase safety. And so a really important part of this is what comes after the screening, and can we make sure that everyone has access to information on what advocacy services are available in the community. So that's this CUES evidence-based intervention that's listed on the slide. So rather than simply doing a screening, and if someone says no, you move on, you do a screening, you do some universal education on healthy relationships, you offer information on domestic violence advocacy services to everyone. So if someone says, no, everything's fine in my relationship, something like, I'm so glad to hear that, I'm going to give you this information in case something changes, or you have a friend that might need help. Because in the screening process, we know that people say no to those questions, even if they are experiencing violence, for a variety of reasons. One of them is fear of systems involvement, right? If I say yes, I'm being hurt by my partner, I have kids, does that mean you're going to call child protective services? Are the police going to get involved? That kind of thing. And so we don't want fear of systems involvement or whatever other fear someone might have to cut someone off from really services that they might want, need, and deserve. And so again, offering that information to everyone that walks through the door, the universal education approach. And the other thing that we've really found in our research, you know, we did a randomized control trial where we had providers who were trained on doing this kind of intervention and offering information to all patients. And one of the messages that really came back in our qualitative work is people felt that when a provider said to them, you know, this is for you to help other people, that was actually very powerful and healing. So for survivors to know that they had this information they could share with friends and family who might be in similar situations and they wanted to help, that was powerful. And just this idea of power sharing, right? When you go see a doctor, a nurse, any kind of provider, and it feels like they have all of this, they're the keeper of information. And you feel like, you know, this person that doesn't know anything. And when your provider says to you, I trust you to be able to help someone else, that can really change conversations a lot. And again, in this moment of COVID, where people are feeling so helpless and so hopeless, it's an opportunity to say, I have something that I can do for my community that can help with a lot of just the dread and depression and anxiety that folks are feeling in general. I also want to lift up this idea of really thinking about how we address domestic violence through an equity lens. Again, because we know that, you know, we have assumptions about who experiences violence and who doesn't, about who accesses advocacy services and who doesn't, really thinking about the disproportionate impact of policing and child protective services on different communities. And so as we develop our policies and really systems level interventions, we want to make sure that we are moving carefully in a way that doesn't contribute to the inequities that we already know exist. So who your partners are, things like, you know, the disclosure piece, not requiring disclosure for folks to have access to services. So the last thing that I'll leave you with, as Kenya mentioned, through the Health Resource Center, we offer a lot of training and technical assistance. One of our key tools is our online toolkit. It's ipvhealth.org, and it helps healthcare providers really think about partnering with local domestic violence programs to build their capacity within clinical settings to prevent and respond to violence. So as you are thinking about your policies, your interventions in clinical settings, know that, you know, you don't have to do this all alone. There are people in your communities that have the training, expertise, frankly, the time to help. And so, you know, developing those MOUs, trainings, warm referrals, and again, as Kenya talked about a little bit, those leadership teams, so that it's not like a one and done approach where you think, oh, we'll have the local, you know, advocacy program come in, do a training. We know everything, we can move on. But a sustained effort to make sure that the needs of survivors are really centered in healthcare settings, because we know that so many patients that come through the door have this experience. I will leave it at that, except to say, again, as we think about COVID and the additional layer of fear that brings in, and the safety considerations, you know, we do have this moment of trying to develop new strategies to reach people who have that extra layer of isolation. And as Kenya mentioned, you know, some of the telehealth strategies that we might be able to employ in this moment and potentially continue, right? Even as we come out of the pandemic. So I will pass it back over to Stephanie.
Thank you very much, Virginia. Appreciate your presentation today. Our next speaker, our fourth speaker, is Mr. Nazir Young, who's a captain in the United States Army and was trained in managing and overseeing youth courts through Chester High School. These youth courts help to facilitate peer-to-peer accountability and reduces recidivism and redirects adolescents away from juvenile detention. So let's please welcome Captain Nazir Young.
Good afternoon, everyone. Oh, there we go. All right. Good afternoon, everyone. As she said, I'm partnered with the Pennsylvania Youth Courts program. And just a broad overview, it's a restorative approach to figuring out solutions for juvenile justice. All right, so the program's core values are in line with Maslow's hierarchy of human needs. As you can see, it starts with sociological needs and then progresses from there. But for the bottom three of Maslow's theory, we found that these basic needs can be termed as resources. And usually when a kid comes, or a student rather, when a student comes to the program, what we found is that they've lacked one of these resources somewhere along the way that, got them into some type of disciplinary trouble. And that's where youth courts come in. From there, they go through the restorative process and we try to have an outcomes-based organization. So I guess I should be remiss and actually discuss what is youth courts, right? So youth courts is a student-ran juvenile justice alternative that promotes restorative justice as opposed to the traditional route for juvenile justice or the school disciplinary system. It's peer-to-peer and it's students being trained by both law professionals, teachers, justice authorities, and they learn the various responsibilities that would go in a courtroom. So your lawyer, your judge, your bailiff, so on and so forth, the jurors. So again, and I'm going to stress the youth court model, and I put Maslow's hierarchy of human needs back into the PowerPoint as reference when I'm describing our pyramid and how it's framed. So for starters, if you look at the sociological needs, right, it starts with food, water, and those are basic things that the human needs to survive. Now, what we're trying to do is promote students that would matriculate through high school and become productive citizens. So the core value of it is we need to, at a bare minimum, stress the importance of the courtroom design so they understand that every society has to be structured in law and order, right? So we set the room up as a courtroom and then we proceed with how the program is governed. The next step is safety needs, right? And as you can see, that's comparable to the youth advocate, which in this case would be the lawyer. It's the first person that the respondent would meet or the offendant. And the youth advocate's sole purpose is to interview and find positive facts about the person that's on trial. And literally the youth advocate's first role when they enter the courtroom is to give an opening statement that puts the respondent in the best positive light ever. What that does is it gives the respondent a sense of security. It gives them safety, comfort, and knowing somebody's there to help them along through this process, just like a regular lawyer, if you will. But the key to the program is the jury. And that's where you get the sense of belongingness, and they begin to implement more of an intimate relationship with the respondent. The jurors are trained to ask empathetic questions that not only projects empathy, but to an extent, it gives off the sympathetic appeal. Like, I understand where you're coming from. And not only do they understand how the cause and effect relationship led to whatever it is that the student did, but they also try to ask questions for the student to be self-reflective and understand how they may have had some actions that contributed to whatever violence or whatever type of actions led to them becoming a respondent in youth court. And then, as you can see, it goes on to psychological needs. And then that's where we have the verdict. And we try and give a restorative disposition. This disposition is not only going to try and have the respondent have self-reflection, but it's also going to try and make amends for whatever it is that was done, whether it been to the respondent or someone in the community. And then from there, after we have the intervention process, typically what we've seen is the students become a lot more productive, which leads to achieve and self-efficacy. I'm not going to spend too much time on this slide because this is solely talking about the respondent where we use the DEAR method. But what I will discuss is the fact that evaluate and redefine is crucial for the respondent. And that's why I bolded that section because they come to us already defined from whoever referred them to youth court as, you know, a troubled child or somebody that's going through something. And what we've seen is that most of them are experiencing some type of trauma. And I'll speak to that later on in the slide deck, but just speaking specifically to evaluating, like I said, the students ask questions that are empathetic, both leading and open-end questions to allow the respondent to explain themselves while having that self-reflection for the respondent. The intent is to evaluate the cause and effect relationship that leads to the respondent's actions. And then we come up with the restorative disposition by asking questions along the line of how do we help the respondent grow with this verdict? How can we rectify and amend what happened? And then from there, after their verdict is read, we get to the point where the respondent can redefine themselves. Do you accept the verdict? Will you action our recommendations? How has the process helped you? And in what we've seen in most cases, the respondent has liked the program so much that they end up coming back to be a juror. And I'm just going to play a quick video to show the relationship after someone's gone through the youth court model.
So I've been out there in the hallway and I talk to kids, and when we have to fill out a little thing beforehand. And sometimes kids pass by and they're like, "Oh, you're in youth court, you're gonna go to prison," or something like that. It's a stigma almost that it's a real court system with like an actual certified judge.
Kids don't always enter youth court with a calm demeanor. They might be upset or frustrated, but I think by the time everything gets settled and situated, you know, they've had a good opportunity to express themselves, express their side of the story as well, so that, you know, they feel like they still have a voice in the process.
It's actually teaching our kids to not write someone off after they've made a mistake.
We try to restore their image. That's what we say all the time, restorative. That's the whole point of the class. It's a restorative system.
I had a conflict with a student. I wrote a disciplinary referral as I would have normally.
In the beginning, when our situation had happened, I didn't like speaking to him. I didn't want to be associated with him.
The student later approached me. He had a letter of apology. I still have it hanging on my bulletin board. And, you know, from reading the letter and just from his demeanor when he approached me, I could tell that he was sorry. He kind of knew that he was in the wrong.
Now, he's my friend. Cool.
Since then, we've had a great relationship and a good rapport.
A lot of the times I'm seeing kids who could potentially fall into a pattern of having punitive consequence after punitive consequence, which what I see in kids is if that happens, they get really discouraged and they actually stop trying to make behavioral changes.
Honestly, when I go to detention, it really doesn't affect me. At least when I have youth court, we talk it out.
It's easy in that environment to feel like they're punished. They kind of bottle up their emotions about it. But, you know, youth court, if they're able to kind of bring it all to the table, express themselves.
Talking it out, you express your feelings in the other way, and like you learn what you did wrong. In detention, you really don't do nothing.
We're really empowering kids to make that change when they're met with that same challenge in the future. What's going to be different about it now?
I thought it really wasn't going to work. It really wasn't going to affect me. I thought it was just like a joke. It wasn't really going to change me, but it changed me for the good.
I wasn't sure that everyone was going to buy into it. And like I said, I'm not sure that everyone still has bought into it.
To be completely honest with you, it does vary. Whether the kid wants their image to be restored or they just want, I just don't want to get suspended.
It can help a lot of people. It's going to benefit them. It's just like, you have to be like mature enough to understand it.
It's kind of creating a culture of students who are willing to give second chances and who are trying to figure out what can be learned from their mistakes.
I've never been in anything where I had an impact on other kids' lives at all. This is, I'd say, the biggest thing I've ever been a part of. So to say that it's changed me is an understatement.
I'm looking forward to a few years from now when everybody is really well aware of it and it's kind of gotten a name for itself?
It's still early, and I think that all the people who have been intimately involved with it and have gone through the process, I don't think that they doubt it anymore.
I think it helps. I think it can help.
So moving forward, I want to discuss the process from start to finish. And I've already alluded to it with Maslow's hierarchy, but typically it starts with a student having limited resources through the various platforms of the pyramid, which leads to no self-awareness, which leads to some poor decisions, and then being mislabeled, which leads them to either youth court or detention. And then once in youth court, we try to counteract what they've already been to and redefine that process. So once you're in youth court, we start with intervention, reflection, acceptance, and then self-actualization. So we decided to put some quotes on here that have come up through youth court, and it's fear comes from a place of uncertainty. And when we asked what is that uncertainty, it was, uncertain of perceptions, uncertain of someone else's intentions, and uncertain of what my actions will cause a reaction for, and how people will respond to some of the things that I do. And then as we started to unpack that, you'll see in the next slide, violence is caused through negative exposure to media, community, and home. These negative exposures leads to frustration, misunderstanding, and poor decision making. So it starts with one person, and then it's like a domino effect throughout the community, which comes into the school, and the process continues over and over. So youth court attempts to come in and disband that, so that the progress doesn't, or not progress, the cycle doesn't continue to go. So in addition to the courtroom model, we also have youth court class, where we discuss various topics that are engaged at making students productive citizens. And an example would be one of the classes we discussed the First, Second, and Fourth Amendment rights: freedom of speech, right to bear arms, and no unwarranted search and seizure. I just embellished, but you get the point. So from there, we gave them basic knowledge, right, of how the amendments work. And then we gave them real life scenarios that they can apply to. And as we all know, the Black Lives Matter movement and the actions thereof of the cops, right? So we asked this question to start the lesson off. Is it fair for cops to operate under the assumption that citizens could have malicious intent? And then obviously they all took the side of, themselves being the person that can be pulled over. So then from there, we asked the next question: is it also fair for citizens to assume cops have malicious intent because they're armed? And then at that point, they can start to see the causality. How does one person actions affect the other person actions? And then they're seeing perception and perspective, which is really the core to understanding everything. And then from there, we asked the final question, and this is an attempt for them to come up with creative solutions, right? And we asked, why do you say thank you to service to soldiers? Thank you for your service to soldiers, but not police officers, when in the grand scheme of things, their jobs are pretty similar. And then kids came up with very creative solutions to what to do. They actually came up with a 7-step process to how to respond to being pulled over by a cop. They also came up with ways they can partner with the police force at changing their community. Several of them left that day saying, man, we should be treating cops differently. And it's not to say that anybody's wrong with the current situation we find ourselves in America. It's to say that no one's taken the time to understand each other's perspective. So I'm going to go to the next slide. Here's some of the benefits from the students being enrolled in the program, both respondents and participants. And I won't spend too much time on this slide, but it goes without saying from the video, one of the kids said verbatim, I'd never been a part of something that helped someone else. So it really empowered just the participants alone, not even the respondent, to be able to help out a friend in need and feel a part of something, that belongingness. Here's some of the statistics. This is from 2016 to 2017 and 2018. We don't have anything current right now, or at least I couldn't pull all that material up right now. But what I do have is proof to show that the program is working. This is one of the middle schools that we're in. They've seen a 34% reduction, and this was one of the first years that it was in the program, in the school. It's risen since then. Here's some of the cases that the program has seen while at that school. So we have assault, bullying, cell phone usage, disrespect to the staff, a fight, sexual harassment, and so on and so forth. And as you can see, the sexual harassment is pretty high. It's at 16.1, right? So now we're getting into more of the higher risk issues within the culture of that school and the community, and how we attack those. And I would be remiss if I didn't bring up the students' own quotes or ways that they feel about the program. Some of them have said, the most important thing I learned in youth court was not how to find better solutions to real world problems and how to become a leader in my school. I learned to understand other people's point of view, right? And this is the key to the program. So again, how do we change fear of violence? By going through the process of youth court, allowing the students to know that someone's on their side, right? And then allowing them to unpack their emotions with peers. The program is also gearing towards advancing the way that we answer trauma, especially in the community. We're seeking to get medical professionals, mental health professionals, to come in after the youth court case, because when these cases are going on, there's still teacher instructors in there. And if we deem that the student may need more help than what has come out in the court case, then we have the option of trying to get them additional assistance. I'll be remiss if I didn't tell you that while I'm giving this PowerPoint slide, I'm actually one of the students that was a part of the program. I graduated high school in 2011. Now I'm in the United States military, but it was within this program where I myself changed. I was pretty much a bad kid growing up for various reasons, but through the program, I definitely seen a shift in the way that I viewed things, which goes back to the restorativeness of the program. And as you can see, the quote in the corner, a mislabeled student before youth court is no different than a diamond before pressure and polishing. And in closing, just remember, empathy is the greatest threat to injustice. And that goes for both sides. Thank you.
Thank you very much, Captain Young, for your presentation. Our final speaker for our Fear Across the Lifespan panel is Dr. Jerry Donnenberg. She's a professor of medicine, psychology, and epidemiology and biostatistics at the University of Illinois at Chicago. She's the co-vice chair for research in the Department of Medicine and directs the Center for Dissemination and Implementation Science, as well as the Healthy Youths Program. Let's please welcome Dr. Donnenberg.
Thank you. Thank you for having me. Good afternoon, and I appreciate the invitation from the organizers to be here today. Just to give a bit of context on my comments, I was trained as a clinical child and adolescent psychologist, and my career has primarily focused on improving the health and well-being of young people, which has included developing and testing sexual health and health promotion types of interventions, as well as building capacity both within the youth, but also among people who work with youth in this area. So I currently, it was mentioned, direct the Center for Dissemination and Implementation Science. And our mission, importantly, is to really reduce the amount of time it takes for an intervention that's shown to be effective to move into the communities that need them the most. So some of you may know that there's a 17-year gap between when an intervention is demonstrated to be effective and when it gets into practice. And so our goal is to really make that that transition much quicker and much more effective. So I wanted to then use my time today to sort of discuss the impact of fear of violence from this lens that I'm coming from. And I'm going to draw on my own experiences, both in the United States and also I do quite a bit of work in Africa, to hopefully illustrate how the complexity that fear of violence has on people working in the area of sexual health and reproductive health and HIV prevention. Next slide, please. Thank you. So many of you may be familiar with this HIV prevention care continuum. It's interesting as I reflect on COVID right now about the very different lessons that were learned for the HIV epidemic and how those might be useful during this time in our responses to COVID. And I'm happy to reflect on that later during the question and answer. But there are similarities to this infectious disease and how it's disproportionately impacting communities of color, much like now the HIV epidemic is doing. And in any case, HIV continues to be an important focus of public health efforts. And while we have been able to see a very important shift from, 30, 35 years ago, it was a certain death sentence, to now you can live a long and healthy life with the chronic disease of HIV, but if and only if you remain virally suppressed. So what that means is you take your medications as prescribed and you are able to keep your virus in check, and so it's undetectable. And in that case, you can't actually transmit the virus and you can live long and well. But this slide demonstrates to you that there are a number of steps in the continuum before you can actually reach viral suppression, which is the very far right side of the slide, is that the smallest bar. So what happens is you begin with these prevention efforts, and then what happens is there's fall off at each step of the continuum. So for example, if you look at the orange bar, this is where someone is diagnosed with HIV. But from there, after being diagnosed, only a subset of those then actually enroll in care. And then from there, even a smaller amount actually initiate ART, which is the medication that prevents, that can reduce your viral load and help you live long and healthy life. And then finally, you have to stay on your ART, and then you can become virally suppressed. So what's important about this, and the lens in which I'm taking for this conversation, is that not everyone has benefited equally from the various science and treatment advances that we've seen. Marginalized individuals and those who are most at risk for HIV transmission and poor viral suppression are typically the same people who are most affected by a fear of violence, should they decide to practice prevention or care. And so what I thought I would do is walk you through a little bit of this continuum again, but really point out how a fear of violence can impact at each of these stages and impact the behaviors or affect the behaviors that individuals are able to enact in order to remain healthy and well. So if we start with the three far left columns where it says prevention, that typically refers to activities that prevent an initial transmission of the virus. So many of these things are like using condoms or asserting yourself in a sexual situation with a partner to say, I want to use a condom, or I don't want to have sex, or I want to know what your status is before I have sex. It may mean taking pre-exposure prophylaxis. Many of you may have heard of PrEP. That's a particular medication that's made out of ART that can prevent transmission if you're having sex with someone who is HIV positive. It may mean refusing drug use, or it may mean having to use clean needles if you are an injection drug user and you have to assert yourself with a partner who wants to give you their dirty needles. Now, so if you consider this whole prevention continuum and think about where fear of violence may enter the equation and how that's going to affect your willingness to enact any of those behaviors. So let's start with stigma. This is something that people who are living with HIV or concerned about HIV are very aware of. There's significant stigma against individuals who are living with HIV. So let's say you are in a relationship with someone and you don't want to, and they don't want to use a condom with you. There is a real fear of, if you insist on condom use, then you may elicit a response from that person that is frightening. It could be a rejection, it could be a slap, it could be rumors that get said about you. Same thing could happen if you want to get an HIV test, let's say. So you move to the orange section of the continuum. Well, going to take a test might alert your community that you think you might be infected. And we have seen in many cases, a community has a very negative response to a community member who is infected with HIV. Similarly, let's say you decide you're going to initiate art to take care of your health and well-being. But taking art, if you're a young person and you have to take it during the day, might alert your peers to the fact that you're infected with HIV, or the school and the teachers may respond negatively. And all of these are experiences, certainly, that the youth that I work with in Africa have experienced extensively. So the fears around these types of responses can really prevent one from moving to viral suppression and moving safely through it. A second example I'll just provide is lack of family support or even rejection. So consider that you have just received a diagnosis of HIV and you are LGBT or Q, and you haven't come out to your family, but you want their support in taking, with your new diagnosis. You really risk family rejection, family abandonment, maybe even family hostility. Similarly, think about the person who wants to engage in HIV care, but their partner doesn't know that they're HIV positive and may become violent if they find the medication sitting in their home. So in many ways, a fear of this kind of violence or retaliation can impact how individuals approach their care and their treatment and their prevention for sexual and reproductive health, STIs, HIV, that can impact a community as well as the individual. And the last factor I want to highlight is mental health issues, because I do a lot of work in this area, and mental health can either increase your risk for HIV because you're less likely to engage in protective behaviors, and it can also decrease your likelihood of being virally suppressed because you don't follow the regimen that's ideal. Next slide, please. Oh, I just kind of wanted to do just one. If you could go back just to the girl, yes. So our research-based interventions have really focused on a number of these barriers that we have found to be relevant and how to build their strengths. So, and we really take a multi-level approach to the factors that might impact a fear of violence so that we can move forward. So this first picture, we focus on building individual strengths. For example, we have emotion regulation strategies to think about how you can plan for the future so that, even if you're afraid, your future, if you can see yourself in 5 years and where you want to be, or 2 years or 5 months, that getting an HIV test could be really important, or taking pre-exposure prophylaxis would be critical. Next click, please. Okay. So this shows families, and we spend a lot of time working with families to improve family parent-teen communication, strengthen their relationships, and we even work with families to support adherence strategies for youth for their children who are infected with HIV. So we go from the prevention end to getting tested, to taking PrEP, to getting involved in care, and we work with families to do that. Next, click. We do, you can do one more. Oh, sorry, go back one. We also work with, many of our interventions that we do are in groups, specifically because we're trying to alter peer norms. So the previous speaker talked about youth and involved in the justice system. We have an evidence-based intervention called Fat Life that we do in groups with youth who are who have been arrested but are awaiting adjudication. And we do those as a group-based program in order to sort of help the youth support one another and change the norms around stigma and bullying and improve norms for safer behaviors. Next one, please. And then we also focus on mental health. We have a program where we do a trauma-informed cognitive behavioral intervention with youth who are living with HIV to help them understand how their thoughts impact their feelings and their behavior. So when there's a fear, how they can manage that fear more effectively in order to practice prevention. And then last one. And finally, the other level at which we work is changing policies. So sex work is work. What's shown here is that there's a strong belief that, you know, there's discrimination and stigma at the level of policies. Sex work is criminalized, and because it's gay sex is criminalized in many places, and because of that, people are unwilling to approach the different factors on the care continuum. So some people won't get tested because they don't want to be labeled as someone who's gay, and then they get arrested and so forth. So our work also tries to focus on changing policies. So in sum, what I'd like to really just say as a takeaway is that from the lens of, I think HIV is just one disease, but I think it's an important one to understand how a fear of violence can impact at many levels of functioning, from the individual to the family, to the community, to the structural determinants that impact health and well-being. And I'll stop there. You can do.
Thank you so much, Dr. Donnenberg. Appreciate your presentation this afternoon. So now we are transitioning to the question and answer session of the panel. And one question that I had, there were actually a number of questions that did come in for the speakers. What role do you think early childhood trauma plays with being vulnerable to fear or multiple levels of fear at an individual and community level? And this is for the panel.
Well, I can speak a little bit, both as a clinical psychologist and as someone who does work in this area. Trauma has a tremendous impact on fear. One of the actual symptoms of PTSD or trauma-focused programming is that you have an alert, an hyperarousal response to something that reminds you of the trauma. And so you can be hyper alert to anything that might come your way. And I think because of that, there's a heightened sense of fear in relation to a lot of things that might make you less likely to respond in more healthy ways. So, and I know that in another day, we heard about how that impacts the brain and the development. There's a lot of literature and research now on how adverse childhood experiences can impact people, you know, young adults, and then adolescents, young adults, and families much later as they move through the lifespan. I don't know if that answers it, but that.
Well, thank you. Anyone else from the panel? So the next question for the panel is, both gender and racial socialization are key factors in explaining differences in conceptualizing fear and risk. How can we address fear through a gender and racial lens while understanding traditional and cultural norms, which may make women and other racial and ethnic minorities more vulnerable overall to violence?
Hi, Stephanie. This is Kenya.
Hi, Kenya.
Hi. So I wanted to try to respond a little bit to the question that you're asking, because we have been, through the FVPSA program, we have done some work around supporting and addressing the needs of male identified survivors of domestic violence. And I think that part of what we've learned, both from male survivors, from local programs, and from state coalitions that have been really effective in being more responsive to what their needs are. I think we've learned a few things. Certainly we want to make sure that services and supports are tailored to their specific needs, but also understanding that fear and help seeking may look different when we're looking at it through a gendered lens, that oftentimes how male identified victims of intimate partner violence may present. It just does not look oftentimes the same, and their needs may not always be the same as what we would consider to be traditional needs that have come out of the historical oppression of women that led to the development of what the current domestic violence service provider field looks like. And so it may not be that oftentimes men are in need, for example, they may not always be in need of shelter. They may be in need of other services, supports, counseling, or other therapeutic interventions. I think that we've also recognized that there may be times in which having an understanding of the presentation of anger or hurt may look different when it comes to men, but it's no less valid, and it also does not have to be responded to on the part of advocates from a fear-based response. But all victims can feel a range of emotions related to their victimization, and you should not treat a male-identified survivor who may be tall any different than you would treat a female identified survivor who may also be tall and expressing anger in a certain way. So thinking through what that looks like and what those responses are. We've also had some challenges around thinking through when male identified parents come in seeking services with young children, to not make assumptions about what's happening there, what's happening with that relationship or their parental abilities. And so needing to think through how do we support both male and female parents in their co-parenting when there has been violence in that relationship, and thinking through how we support the needs of the children that have been exposed to that violence in terms of not only safety considerations, but then also safe exchange and visitation, including financial support and what that may look like. We've done a fair amount of work with the Office on Child Support Enforcement to make sure that children have the financial resources to get their needs met through their parents. So thinking about that. And then the last thing I was gonna, there was one other thing that I wanted to, so the other thing I wanted to touch on was that in some ways, I think that they're just in the victim advocacy field. I think there's also that when we're thinking about a gendered lens, there's also that very real fear that comes out of some regions and parts of the country where men's rights groups are very active and have done things to really undermine the work that's been done in order to support victims of domestic violence. And our services are voluntary. They are not dependent upon one's gender identity. And anyone who is experiencing victimization can come in and seek out those resources and supports. But there is still that underlying fear that programs may be manipulated or taken advantage of by people who use abuse and by some groups that have really sought to undermine the services that are available. So I just wanted to touch on those few points.
And in addition to that,
Thank you.
we have to acknowledge that there not only there gender and sex differences in physiological and pathophysiological as well, not only the initiation of stress and fear, but how they differ in terms of processing information, and then how does those leads to, you know, gut permeability, for example, you know, inflammation, subclinical cardiovascular disease. They all have different pathways. I think we have to acknowledge it and study it as well.
Virginia, would you like to chime in?
Well, I was just going to say, you know, many of us spoke about stigma and that being a real fear for folks. And so really thinking about how we need to change our cultural norms, whether it's gender norms. You know, it's not up to the person experiencing violence to moderate or change. It's really our cultural kind of the soup that we're living in. And I also think it's really important for us to kind of uplift the messages of health, safety, resilience that are in communities. Oftentimes we focus on deficits and, you know, needs, and really we know that there are already traditions, values, customs in all of our communities that support the kinds of safety and relationships that we want to see for everyone.
And Virginia, you touched on a very excellent point. So how do we shift focus from an individual, individual responsibility to community solutions? Kenya, any thoughts?
Yeah, I was going to say, this is Kenya. I can speak a little bit. I do think that being open to continuous learning and identifying where there can be opportunities for expansion of services and supports. And sometimes I think what we've learned in our work with other federal agencies is that sometimes even the slightest change can make a huge difference. So thinking about ways in which you can begin to add language into any, for example, funding opportunity announcements, into any technical assistance briefs or guidance that goes out, raising questions about these particular issue areas in conversations with grantees or those that you may work with in your community, and being a constant voice to highlight these issues and think about what the intersections are, I think can really help move things from that individual experience into more thinking about what's the action that can be taken here. Sometimes when we try to move the mountain, that may not always be the best approach, but there can be small steps that can happen over time that can continue to increasingly lead up to a shift and a change in how the work happens. And I think that can be difficult at times. You know, people want change right now. But the reality is that change is progressive and that it happens steadily over time with continued focused effort. And I think the more that folks can continue to push and be active in that way, the more helpful it is. But really building those networking relationships and thinking about ways to leverage resources, I think can be really important to helping identify those community-based solutions. I also think really listening to the community and allowing the community to lead and drive and move that change forward. There was a question that had come up earlier, I believe in the chat, around like the needs of tribal communities and what their response is. And I think that's something that is vitally important, is really the listening, the storytelling, oral history, and how that gets passed down from generation to generation and throughout communities. Is really being respectful and listening and learning and allowing the community to come up with what the solutions are, and not always imposing what systems think is the only way or the best way to do something, but really being open to change and being able to be flexible where there's opportunity to do that.
And Kenya, while you have the mic, I'm sorry, go ahead.
I would also just add that, you know, we actually have some really good evidence on community level solutions, right? So the CDC has many technical packages that really outline different, at all levels, how we can do a better job of prevention and response. And that includes systems levels, interventions around policy, and social norms change. So we have some good guidance. And as Kenya mentioned, it's really important to take those evidence-based strategies and be able to adapt them so that they're culturally resonant.
Thank you, Virginia. So, but for both you and Kenya, are you aware of any research on IPV and fear of violence that have been published recently?
That's a good question. Specifically on fear of violence, not that immediately comes to mind. I know that there's been other published research on different things. So I would have to think about that a little bit to recall something very specific that I could share with the group. Yeah, so I'm just gonna pause there.
I do believe that there has been a number of research published in regards to adverse childhood experiences and its relation to fear and domestic violence. So I do understand that there is some literature that have been published in regards to that topic area.
Great. And I know there was also another question that had come up about same gender intimate partner violence. And I do want to add that FVPSA also funds the LGBTQ Institute on Intimate Partner Violence. And they do phenomenal work, and they have really worked to put out resources and information and research about how to do assessments for predominant aggressors, and to help identify those, not necessarily based upon voice or gender cues, but really to look at and understand the dynamics that are present and that are happening in that particular relationship, in order to understand who is being the predominant aggressor and who is identifying as the victim in those situations. And they also have put out a lot of great information to help work with our local programs around how do you support folks that may identify as transgender in terms of accessing shelter and other supportive services. And they've also done a lot of Q&A listening sessions where they really talk with young people in the community about their identity, about their needs that they have in order to respond to when they may be experiencing violence in their relationship. And part of what also comes up is that, and I think it's been touched on by a few of the presenters, around the fear and the stigma that's associated with being someone who identifies as being in a marginalized community, perhaps may be at various stages in terms of coming to terms with their own identity and what that means, and what that impact that may have on their own lives. And then also to perhaps be a person who's experiencing violence and abuse in that relationship can sometimes be very difficult. And so I think the focus on promotion of healthy relationship behaviors is very important, and especially with young people and youth, to help promote that. So that regardless of the type of relationship you're in, every relationship should be mutually respectful, and should be caring and loving, and not involve abuse or violence in any way.
Thank you, Kenya. I think we have 1 more minute for questions. And so I will now ask for Captain Young. There was a question that was posed, or 2 questions that were posed for him, and I believe he's back on. Captain Young, have you published any data regarding your peer-to-peer programming?
He may be on mute.
Hi, Captain Young, I think you're still on mute.
He's been prompted to unmute, but he has to click OK.
I'm sorry, I just came back to the office. Was there a question? I'm sorry.
Yes, sir. Have you published any data regarding your peer-to-peer programming? And also, had the kids suggestions, they had questions in regards to suggestions the kids had for the police for better interactions and resolutions within the community?
So there's published work. Unfortunately, I don't have it, but the program administrator does. I believe I dropped his email in the chat link, but I don't have that data right now. Did I answer?
And any lessons learned from the kids, your cohort, in terms of having better interactions between those children and the police, or the community and the police?
Yes. So we've actually had several police officers come into the high school and speak with the kids, and the interactions changed drastically. When they first came in, those kids are funny. When the police officers first came in, they were not okay with it. And then throughout talking with the police officers and both of them giving perspective, the kids grew a fondness for the program. And there's actually been talks about having a police mentorship program come into the community now. Now, it hasn't happened yet, but it's been talks about it.
All right, great. Well, I'd like to thank all of our speakers today for their informative presentations. I will now pass it on over to Emmy.
Great. Thank you all so much for really interesting conversations with common threads and obviously some differences in how we address these things. We are going to take a short break now. We will reconvene with speakers starting at 1/4 till, so 2:45 Eastern Time, 12:45 Mountain Time. And please do come back for a great session. And this will continue broadcasting during the break, so please make sure to mute yourselves. Thanks, and see you soon.
Hello.
Nice, yes. Welcome back, everyone. I think we'll go ahead and get started again. This next session, which is actually our last session, will focus on larger resilience threat management frameworks, as well as trainings that address fear of violence. And we have 3 speakers. Dr. Megan Ranney is the Warren Alpert Endowed Associate Professor of Emergency Medicine at the Alpert Medical School of Brown University. She's also the founding director of the Brown Lifespan Center for Digital Health and co-founder of Affirm. David Mitchell is a lecturer, director, and chief of University Police at the University of Maryland. And Jonathan Links is a professor at the Johns Hopkins Bloomberg School of Public Health. David Bixler, we have 4 speakers. David Bixler is co-leader of the Boeing Company's Enterprise Threat Management program. So I think we're all excited to hear from our speakers about how fear of violence relates to their interventions and their recommendations for managing, reducing, and preventing fear of violence. And we'll start with Dr. Ranney.
Thank you, Emmy. It is a joy to be here and to join all of you virtually. I'm going to share my screen, so just bear with me for a moment while I get this going. All right, folks. Thank you for your patience. All right, should be good to go here. So I'm going to talk about the fear of gun violence and what we can do to change it. Let's see. So as Emmy mentioned, I am an emergency physician. I am the director of our Brown Lifespan Center for Digital Health. And I'm a federally funded researcher focused on the overlap between violence and mental health. Most of my own work looks at how we can use technology to both identify and prevent the mental health consequences of violence. I'm also, as Emmy described, the co-founder and chief research officer of an organization called Affirm, or the American Foundation for Firearm Injury Reduction in Medicine, which is a nonprofit focused on developing nonpartisan, community-based public health approaches to firearm injury. As I'm going to talk a little bit today about my perspective, both as a researcher and as an emergency physician, on how violence and fear are overlapping, and then I'll talk about what we can do to change that. So from my perspective, there are really 4 ways in which fear interacts with gun violence. The first is the fear of the other, the fear of the person who may perpetrate gun violence against you. The second is the fear of the object or of the gun itself. The third is the way in which fear interacts with our treatment of victims of gun violence. And the last is the way in which fear permeates all of the after effects of every episode of firearm injury or death that we hear about, whether within an individual community or within the media. So the first is how fear drives why people own guns. This is particularly pertinent right now in the midst of COVID-19. This picture comes from a publication from the National Shooting Sports Foundation, which is basically the trade organization of gun shops across the country. They report that there were more than 2.1 million new purchases in excess of the same period last year during COVID-19, and approximately 40% of those were first-time gun buyers. That number increased briefly because of fear. People have a fear of other, of breakdown of society. Structural racism is deeply implicated into reasons for purchasing guns. There's a fear of people that don't look like you, who might threaten your way of life. And there's that fear that in the midst of COVID-19, that everything that we know is going to fall apart. I'm sure that all of you who are watching this, just like me, had friends and neighbors who talked about what would happen if looters came to our neighborhood. What would happen if the police cease to function? What will happen if our schools don't go back? That fear leads to people thinking they need to arm themselves. The trouble, of course, is that during COVID-19, most of those people who are purchasing first-time guns are not getting appropriately trained, and so their fear may be misplaced. We do know that self-protection is the fastest growing reason for firearm purchase. And that applies not just to kind of the stereotype of the rural white male buying a gun to protect himself, but it also applies to gun ownership in our cities. We know from studies done across decades, most famously one by David Hemingway, that there is a false perception that everyone else owns guns. If you survey kids in Dorchester, Mattapan, and other predominantly low-income areas of Boston, you find that approximately 2 times as many kids think own guns as actually do. That drives people to try to get a hold of one, because if you think that you're going to be threatened, you want to be able to respond. And of course, the more guns that are sold, the more firearm injuries and deaths that happen and are covered by the media, and then the greater the number of people that actually buy guns for that reason. That's the first way that fear influences gun violence. The second way that fear influences gun violence is, of course, the fear of us or our families being hurt. We have a huge fear of mass shootings. That's what has driven so many of us to talk about gun violence again. You know, I don't need to repeat for this audience what has been said in prior days, but we know that starting in 1996, the CDC was systematically underfunded for research on firearm injury prevention. It wasn't until 2012 and the Sandy Hook shooting that people once again began talking among the political and intelligentsia classes about the importance of addressing firearm injury as a public health problem. Our willingness to do that directly related to our perception that it was our kids who might be getting hurt, right? We're all afraid of putting our kids on the bus, ignoring the fear that has been permeating our cities for decades. Now, of course, that fear is, again, misplaced. Just as that fear of other that drives people to purchase guns is erroneous. We know that people who own guns are actually at greater danger of themselves or someone else in their household getting hurt than of having a stranger come to their door and shoot them. Similarly, we know that in the United States, although we are all afraid of mass shootings, actually 2/3 of gun deaths are suicides, and more than 100 people are killed every day across our country. So this fear drives people to fight gun violence, but it drives them to fight it perhaps in less than ideal ways. It leads to people thinking that the object is the problem rather than the way in which it is used. It leads to people being driven by anxiety and, for some, by post-traumatic stress rather than by an evidence-based approach to how we can actually prevent gun violence. The third way in which fear interacts with gun violence is the relationship between gun violence and our treatment in the healthcare setting. For those who have heard me speak before, I often start my talks with a story about a young man I took care of many, many years ago now, who came into my emergency department having shot himself. He's one of only 2 patients I've taken care of with a purposefully self-inflicted gunshot wound. And that moment to me really changed my relationship to gun violence, and it highlighted the way in which we treat victims of gun violence differently because of the fact that they are injured with a gun. We have a fear of not being able to help patients. There's this sense of fatalism around firearm injury. There's certainly a fear of being injured ourselves. There have been a number of high-profile news stories about physicians, psychologists, and others who have been shot and killed on hospital or clinic grounds. And of course, we have a fear of the active shooter, especially in emergency medicine. The mass casualty incidents that dominate the fear that drives the gun control movement also dominate much of our response to gun violence. We spend inordinate amounts of time within the hospital setting prepping not just for an active shooter on the hospital campus, but also for how we would respond should there be a mass shooting in our community. Finally, fear influences our relationship with gun violence because it's a consequence of it. I and others have shown that communities and individuals who have been affected by gun violence, whether directly or indirectly, so whether they themselves are victims or whether there is have simply been incidents of firearm injury in their community, folks living in that area have higher rates of anxiety, depressive symptoms, post-traumatic stress, substance use, higher rates of other risky behaviors like sexual risk behaviors, higher levels of hopelessness, and higher levels of other somatic and medical issues, things like headaches, insomnia, and some recent studies showing increased rates of chronic disease, which I know you all have talked about over the last few days. So fear permeates every aspect of why gun violence happens, why people own or hate guns, and how we respond to it. But it doesn't have to be this way. One of the precepts of our public health approach, of course, is that we can fight even these seemingly intractable societal and medical problems. And there are a number of ways that we can take action to reduce the incidence of firearm injury and death without falling prey to these stereotypes about why gun violence happens, whether, again, it's a fear of other or a fear of the object. So here I'll come to a model that I'm sure others have talked about over the course of the past few days, which is the social ecological model, right? It's the idea that everything that happens in our society has a series of risk and protective factors that start at the individual level and go out to the societal level. For us to reduce gun violence, it is essential that we reduce fear, that we take this discussion out of the politics, and that we make it individually relevant and powerful. So we need to work on all four of these levels of the social ecological model. My personal focus is very much on the first two, on the individual and the relationship level. So many of my own interventions are apps or text message based or person-to-person virtual interventions that change cognitions and feelings, that use well-established strategies of cognitive behavioral therapy, motivational interventions, and peer support in order to both change fear of firearm injury happening to a person and change one's response to violence that has been experienced. These have been shown in pilot studies to be effective, and I know that others have talked over the last few days about the variety of ways in which we can intervene to reduce those post consequences and then reduce that retaliatory cycle of gun violence. We're also doing preliminary work, not just with youth or with those who are affected by community violence, but also with groups who are afraid of violence being inflicted on them. The folks who go out and buy a gun for self-protection, talking about, again, how to change those individual and interrelationship cognitions about what makes them afraid of gun violence, and then change the reasons why they may choose to own a gun and how they choose to handle it. The community and societal levels are also important as well. At Affirm Research, our focus is much more on those outer levels. We talk about the importance of educating those in healthcare, of changing the way that treatment happens and using that as a moment to change prevention, so that healthcare providers don't think about firearm injury simply from that perspective of fear, but rather think about it from a perspective of empowerment, of identifying who's at risk, which has a small aspect of fear, but reframing that, right, to allow us to intervene and reduce future incidents of firearm injury. There's also the community level, which is, again, changing that perception of what gun violence is and isn't. It may be, if I'm doing a workshop in Brooklyn about changing the perception of the incidence of mass shootings, and rather talking about other ways in which we can reduce risk of violence through things like changing our environment, by greening vacant lots, by providing better education, by reducing structural racism. Or it may be through those community-based events of sharing stories about what gun violence really looks like in most communities across America, which is not a stranger coming up to your door and shooting you, but rather someone within your own household shooting themselves or someone else. Thinking about how we can identify and intervene to reduce those risk factors, and normalizing a discussion about gun violence that helps to acknowledge fear and then put it to the side. Throughout this research, we find that many of the behavioral models that we have talked about over eons actually work. The health beliefs model, the theory of planned behavior, are the understructure of how we can shift these cognitions and behaviors. We know that we need to change knowledge first, right? So again, it's that sense of what is the incidence of the type of violence that you most fear? Who are the people who are most likely to perpetrate it? And how do you best protect yourself from it? It's then about changing attitudes towards gun violence, beliefs about who the other might be, attitudes about what owning a gun actually does in terms of protecting you, and if you do choose to own one, how to do so safely. Changing norms about what you think everyone else in your community does. Going back to those youth in Boston, it's about changing the expectation that everyone else around you owns a gun. Or if I'm talking to Dr. Betz's colleagues and neighbors out in rural Colorado, it's about changing the belief that everyone around you owns a gun as well. We have to do those initial steps before we can change behavior. And on that societal level, we have focused so much on the importance of changing policy without talking about those individual level behavioral changes that need to happen first. The last part of doing this is really about relabeling gun ownership. So one of the deepest parts of the fear about gun violence that I've found over the past decade of doing this work is that the two sides have become reified in this belief that gun ownership is either good or bad. And the reason for that belief lies in what one's underlying fears are, and whether you think that having a gun is going to protect you from that fear or increase the fear. At Affirm, we've been using an approach that we call the reframe, where we bring communities together to share stories about their experiences with firearm injury, going along the spectrum from injury and death right through prevention, in order to start to shift perceptions of what gun violence is and can be on both sides of the spectrum. And I think I am just about out of time now, so I'm going to stop there and leave space for us to do questions and answers.
Wonderful. Thank you so much, Megan. And we'll now move up right to David Mitchell. And David, we have you on mute. There we go.
Good afternoon, ladies and gentlemen, and how great it is to be part of this great opportunity to talk about fear. And certainly something that is a daily conversation. I can tell you it's a daily conversation here on my campus. And bear with me while I bring up wrong one. While I bring up this PowerPoint. Okay. And can I get an amen that you can see the PowerPoint?
Looks good.
Looks
Okay.
perfect.
All right. I usually look for a thumbs up, but I don't see any pictures. So I'm going to talk about, obviously, the subject of what we've been discussing, managing, preventing, and reducing fear of violence. And this is a practitioner's perspective, if you will. I do research, and I teach here as well as at Johns Hopkins University. But this is more of a perspective of someone who's out in the field, if you will. So who are we? Well, at the University of Maryland, College Park, we're the 26th largest campus in the United States. We're a medium-sized city, 60,000, 40,000 students, 20,000 staff and faculty. And then you add the city of College Park right next to us, you add another 30,000 on top of that. We balloon up to the biggest, one of the biggest cities in the state on football weekend days. Of course, hopefully we'll see football this fall. Our mission, very simply, protect people and property of the University of Maryland. But we go beyond that. I add to that, reduce fear and improve quality of life. And it's what I talked to a lot of my colleagues about. The absence of war isn't peace. And the absence of fear is wonderful to a community. So, but it's also not a healthy neighborhood. We're part of it. Public safety, police are part of the safety of the community, but we're just a part of it. And we can do our part to reduce fear. and improve quality of life. I can show you these numbers that demonstrate that this is one of the safest places on earth, actually. This is the past 10 years of crime on my campus. Tragically, we've had one murder. I'm going to talk about that. That was in May of 2017. Rape, of course, is underreported. We're well aware of that. But when you look into other forms of violent crime like robbery, aggravated assault, and so forth, you can see, again, a population of 60,000 people. These numbers are relatively small. Burglaries, we have a few. Our biggest problem here in reported crime is larceny, or what we call theft. Theft of, you name it, theft of a cell phone, a computer, a bicycle, and so forth. Motor vehicle thefts, we reported to the FBI 23 motor vehicle thefts last year in 2019. Most of those were golf carts. The FBI says, well, it's got 4 wheels and a motor, so it's a vehicle. But of the 23, maybe 3 were actual automobiles. The rest were scooters and golf carts. And you can see we hardly ever have any forms of arson. Now, you know, given that our campus is that safe, we still maintain our blue light phones. We have hundreds of them all throughout campus and off campus into the city of College Park. Why do we keep them? Well, what we have found through surveys is that students and visitors and faculty in our workforce feel safe, and so they feel less fear, reduced fear, when they're traversing campus, especially at night, and they see a blue light phone. Yes, we carry cell phones. Our blue light phones are hardly ever used to call us, but they're a symbol of safety. People know they're there. We also use them to broadcast messages because we can pipe into them and broadcast a message. They have cameras in them as well. So we go the extra mile in maintaining blue light phones. A lot of campuses have gotten rid of their blue light phones. We've opted to keep them specifically for this reason. This has been a hot topic throughout the country. It's called the 1033 program. Essentially, after the wars in the Middle East, and certainly they're not over, but there's been a lot of surplus military equipment, especially after the Gulf War and so forth. And the idea was to make some of this equipment available to local police for their use. So a lot of police departments have done that. Probably gone overboard. We don't need grenade launchers. We don't need, I don't believe we need some of the MRAPs that I see out there. But there are items of equipment that can be beneficial to law enforcement. And of course, there was a big swell of support for this after September 11, 2001. Here you see our emergency rescue vehicle. It is armored. We got it from the 1033 program a number of years ago. It's an emergency rescue ambulance is what I called it. You can't get parts for it anymore. It's inoperable right now, and we're in the process of returning it back to the military. Now, when I say surplus military equipment, it's not given to police departments, it's loaned to you, and you have to maintain it and so forth. I can't afford to maintain that vehicle anymore. I'm gonna miss it though, I can tell you that. What you see here is it's parked on at Maryland Day, which is where we have between 80 and 100,000 people that come on our campus and interact with us and so forth. And you can see the vehicle there. A lot of students come by and take pictures. If I had somebody, an active shooter, that, heaven forbid, that caused and wreaked havoc and shot people, students and others, on this area of Maine administration, I'd be hard pressed to go in and rescue them without an armored vehicle. That's why we have this vehicle. So I'm returning it to the 1033 program, and I'll rely on Prince George's Counties, who is our allied agency partner, along with the Maryland State Police. They are equipped with rescue vehicles. If we look back at active shooters, going back to the University of Texas, 1966, Charles Whitman up in a bell tower, shooting students and so forth. Then we had a long lull after that. By the way, he was killed by campus police when they confronted him and he shot at them. Of course, we remember Columbine High School and the tragedy that occurred there. That was a bellwether event in law enforcement. We used to get on the scene of shootings and say, okay, contain and negotiate. Block it off, contain it. Call a SWAT team, call hostage negotiators, and we'll just wait until they get on the scene and do what they traditionally do. Well, you really can't do that if people are inside a building or anywhere for that matter, and they're continuing to wreak havoc, they're continuing to take lives and so forth. We can't do that. We have to suck up, we have to go in. That means we have to be prepared, obviously. We saw that in Virginia Tech with a student by the last name of Cho, which caused us and many other campus communities to develop programs where you can call in quietly and anonymously, actually, of fear for others who are acting strange or talking about bringing harm. Las Vegas was another bellwether event. There's a man in a hotel shooting into an open air country and western festival. Well, that certainly caused a lot of fear within my department because our football stadium is surrounded by high residential facilities and classroom facilities and so forth. So the threat picture is always changing. Of course, then we look at that the number one question up until about a year ago from parents when I do student orientations was, how well are you equipped and trained to handle active shooters? Well, today it's, well, what about Ferguson, Minneapolis, Seattle, and Portland? Look what's going on there. And the tremendous loss in confidence in police and the friction that we now have to deal with throughout our country and on our campuses. So we have to come up with alternatives. I returned all the 1033 program. I don't have any more 1033 program. Got rid of the M16s. We switched over to patrol rifles, which make a lot more sense. They're not full automatic weapons, nor do we need full automatic weapons here on campus. By the way, our campus community, our students applauded us for doing that. And it's not caving in, it's not giving in to student demands and so forth. It's finding a way to work smarter, not harder, and reducing fear. When you see police forces armed and dressed in military battle dress, pointing weapons at unarmed protesters, it's going to cause fear, and it's going to cause friction, and it's going to cause a loss of confidence. Of course, we're prepared for active shooters, but we'd never use any of this equipment against unarmed, peaceful demonstrations. Well, we did have a murder. On the right-hand side, you see Lieutenant Richard Collins III, who was an ROTC student, graduated, newly minted second lieutenant in the United States Army. He was on my campus about 75 yards from the front door of my police station here on graduation weekend in May of 2017, standing at a bus stop with several other friends. Even though he went to Bowie State University, he lived in the College Park area and he had a lot of friends here on this campus, and he was enjoying the night and was standing with some of his friends at the bus stop. While standing there, Sean Urbanski, a University of Maryland student, approached Lieutenant Collins, told him to step away if you know what's good for you, and then stabbed him. Tragically, and despite the efforts of my officers that did CPR and kept him alive until he got to the hospital, tragically, Lieutenant Collins died. When we drilled down into who Sean Urbanski is, we saw a link to a Facebook group that was obviously a white supremacist. Needless to say, this information caused fear to tidal wave through my campus, particularly for students of color and their moms and dads. We're still dealing with it. Sean Urbanski has been convicted of murder and he's awaiting sentencing. But I'm still dealing with the fear from this event. We saw in subsequent years, the applications of African Americans dropped, in part because people don't want to come here because of the fear of what happened. This is the first known murder to happen in the history of the University of Maryland. Certainly one too many, but it's not as though we have a lot of violent crime. You can't prove that though when you hear that story. Well, and like the rest of the world, we engage in a lot of social media now. Social media can exacerbate fear. Research shows that those who watch the news, who engage in a lot of social media interaction, have greater senses of fear of violence than those who don't. I understand that. The news media, and I was a press information officer for a while in my career. Sometimes they say if it bleeds, it leads. I can tell you that tragically, the Baltimore news, I watch the Baltimore news, and every night it's about murder and mayhem and so forth. And certainly leads you to believe that nobody is safe in the city of Baltimore. I know that the chances of you being murdered in Baltimore are small. But however, that's not the feeling that people have when they hear the news about it. Well, social media can help reduce fear as well. That means you have to be very, very active on social media. I'm fortunate enough to have a staff member here who is our social media monitor. And she's a sergeant and routinely puts out good news about what we're doing. Pictures of the police and students engaged and so forth. Closing out criminal cases with arrests and so forth. It keeps the community informed. We're unique on a campus because by federal law, the Clery Act, I must send a community notice, an alert, a timely alert, anytime there's a violent crime committed on this campus. Now, a lot of police departments don't have that federal law mandate. We do on any campus community here. One of the things we've done to help reduce fear is a Guardian app that acts as a Guardian app. You pick your Guardian. It could be your roommate, mom, dad, somebody else. And when you are going from point A to point B, it's an escort feature where you can type in where you're going. And when you get there, the app knows you're there, you're safe and so forth. If you don't check in, it's going to automatically call your Guardian, who would then automatically call us. Very popular, it's free, and it's one of the things we did to help with regard to fear. Our Student Government Association just released 15 demands. One of them is for more community policing. Well, needless to say, that's music to my ears. So it's more opportunities for non-enforcement contacts to build relationships. One of the difficulties in campus policing, and particularly a big campus like this one, I lose 25% of my population every year. I have 5,000 graduates plus, and I have 5,000 freshmen coming in. So it's a constant effort to work to reduce fear and to engage our community and to make friends and so forth. They're only friends here for a while, and then they're moving on. We want it to be the best experience they could have in an educational setting. Well, where are we going next? Well, we just got new leadership. A long time dean of our School of Engineering, Daryl Pines, was just appointed president of the University of Maryland College Park. He comes on board. He is absolutely supportive of UMPD's efforts, of what we're doing and so forth. He's also very tuned in to some of the fear that's in the campus community. He and I have had several talks about that. We have a Black Lives Matter march tonight, along with a picnic. We will have officers there, a few. They will not be dressed in battle dress uniform. They'll be wearing their regular uniform of the day. They will engage the campus community, our students and so forth. And we look for a peaceful demonstration. And that's what our president asks for, and that's what our parents ask for, and that's frankly what our students are asking for. The bottom line, and I've been in this for over 4 decades, the bottom line is essentially this. There is this, and it's a little elusive, concept of community goodwill. Now, it's like a bank account. We're writing checks against that account every day. Unlike the fire department, not everybody's happy when the police get there and arrest somebody. I mean, the victim of the crime might be happy, the perpetrator won't. And some people may see the police and think that we are infringing on constitutional guarantees. We're constantly replenishing the community bank account of goodwill. We do that through one contact at a time. We have a task force on campus policing coming. You know, if you hire, train, and supervise properly, most police departments are not going to have problems. And market all the good things that you do. That's the future of what I see in helping us to answer the call, reduce fear, and improve quality of life. With that, I want to leave plenty of time for any questions that may be out there. And Corinne, the floor is yours. Thank you.
Excellent, thank you. Well, we will save questions till the end. And at this point, we will move over to John Links.
Good afternoon, everyone. Alejandra is going to load up my slides. As the saying goes, now for something completely different. So what I'm going to be talking about is the work we're doing in systems modeling of functioning and resilience post-traumatic events. I want to start by contextualizing what I'm going to talk to you about. And SAMHSA describes individual traumas resulting from an event series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And the reason I start with that quote is to make the connection between trauma, traumatic events, fear, and functioning. Obviously, violence is a form of trauma that can and has been equated with other forms, including disasters. That's where my research lies. And fear can itself, of course, be conceptualized as a trauma. And so that brings us to resilience. And we're interested in resilience at the individual, organizational, and community levels. And resilience has, of course, been a focus of both trauma and disaster management. I'm here because we've developed a systems model of community resilience that predicts the time course of functioning from which resilience can be derived. And I'm going to talk about that model in a moment. And we've recently created an analogous model of school resilience in the face of violence and other traumatic events. And I'll say a word about that as well. Next slide. So let's go back one. Thanks. So to contextualize everything I'm talking about. So think of a community of any geographic scale, and it has some baseline level of functioning. In our computational model, it's a value between 0 and 1 on a normalized scale. And that community is going along and some sort of traumatic event, disaster event, etc. occurs. And there's a drop in functioning. And the first thing we're interested in is a metric called resistance, which tells you something about how far a drop a given community experiences in the face of this event. And the greater the resistance, the smaller that drop, that is, the smaller the initial loss of functioning. I certainly have given it everything I have. And then after the functioning reaches its nadir, there is a return of functioning over time, which we call recovery, and which we quantitate as 1 over the half time to recovery. And the greater the recovery, of course, the quicker the return of functioning back to a baseline level. And resilience can be conceptualized as the green area under that functioning time course. And the important point is it depends on both resistance and recovery. And the factors that influence resistance and recovery are different. I'll say more about that in a minute. And so the intervention strategies have to be different to enhance resistance compared to enhancing recovery. And I hope it goes without saying that violence and fear of violence can be conceptualized as events that reduce functioning, and that resilience at the individual, organizational, and community levels can enhance the posture of the individual, the organization, or the community in the face of violence and fear of violence. So next slide, please. So this is a pictorial representation of our system dynamics model that predicts community functioning during and after disasters. We call it COPEWELL. That's an acronym. It's not important what it's an acronym of. We came up with an acronym that just sounded cool as an acronym. And this work is supported by CDC. And I'll show you in a minute how we apply it. In this picture, the center is a reservoir of blue community functioning liquid. And the level of that liquid varies over time, and that's what we're trying to predict with the computational model. The initial level of blue liquid in that community functioning reservoir is set by a number of pre-event domains shown on the left in the brown box. And these are standard domains that describe how a jurisdiction provides services to the inhabitants of that jurisdiction. At the very bottom of the slide is the event. And when an event is triggered, for example, when a community experiences a disaster, you can see a vertical arrow up to a little circle with an X in it. Think of that as a valve. And the event opens the valve, draining community functioning blue liquid out of the reservoir. Now, there's a series of resistance factors shown in green that are fighting the event's opening of the valve. That is to say, these resistance factors fight the initial loss of functioning caused by the event. And in our model, we separate the resistance factors into two groups: population factors, vulnerability, inequality, deprivation. You can think of those as social systems factors. And then prevention and mitigation factors. So features of the natural systems, the engineered systems, and then countermeasures, which become particularly important when we're modeling a pandemic as opposed to a natural disaster. And so those resistance factors are fighting the drop in functioning. At the top of the picture, you see recovery factors, which replenish community functioning after it's lost. And we have three main sets: social cohesion, which for us is really a surrogate or proxy of emergent collective behavior on the part of the populace in response to a disaster; more formal preparedness and response activities; and then external resources. And each of those factors is represented by its own reservoir of blue liquid that can drain into the main community functioning reservoir, thereby replenishing functioning, leading to recovery. You can also see three circles with X's, three other valves, and there's a feedback loop from the community functioning time course to those valves. The disaster literature clearly shows that those replenishment or recovery factors get provoked more, get activated more, the greater the loss in community functioning. So that's built into our system dynamics computational model as well. Next slide, please. In practice, we populate that system dynamics computational model with publicly available data representing each of the domains in that model for every county in the United States. And then we can run the model for various types and magnitudes of event. And so this is just an example of a natural disaster with 3 different event magnitudes. And the predicted resilience, of course, not surprisingly, drops as the event magnitude increases. A larger event, communities are less resilient too. We complement this work with some other tools I'm not showing here. So there's a set of self-assessment tools, we call them rubrics, which jurisdictions of any geographic scale can use to rate their own performance and then plug into the model. We also have a set of tools for directed conversations among stakeholders and so forth. Next slide, please. This shows you our analogous model for a school. And so you see school functioning instead of community functioning in the center. To the left, the pre-event functioning domains. We have a series of factors representing school performance, school environment, and then student functioning. And those are both individual and environmental factors. The resistance factors are things like social cohesion, active and proactive threat assessment and mitigation at the school level, school building hardening and security enhancements, bullying, monitoring, and mitigation, and so on. This is just a kind of synopsis of all the factors. And then at the top of the slide, you see the analogous recovery factors, school safety planning, school resource officers, and interoperable coordination with the local community. And we're now in the process of populating this model with publicly available data at the school or local education agency level across the country, as well as working specifically with Baltimore City on custom data to populate the model in 3 test schools. With respect to both Copewell and Schoolwell, the point I'm trying to make is a holistic, whole of community view of functioning and resilience that distinguishes between 3 important things: baseline functioning, resistance factors, and recovery factors. A final slide, please, Alejandro. So with that, I was asked to make some recommendations for preventing, reducing, and managing fear of violence. And obviously, I'm going to do so through the lens of resilience. And so as I suggested at the outset, and you all know way better than me, violence and fear of violence should be conceptualized as forms of trauma and its consequences. And the broader trauma framing should drive mitigation efforts. Said another way, I recommend that violence and fear of violence be addressed as part of a larger resilience enhancement effort rather than as a specialized effort. And that resilience at the individual, organizational, and community levels should all be addressed, noting that the enhancement strategies differ at these different levels. Resilience enhancement and trauma-informed care should go hand in hand. And finally, the positive and negative aspects of trauma experience should be folded into the approaches. Thank you very much.
Thank you very much. Very enlightening presentations, and I am now going to turn the podium over to David Bixler. Thanks, Dave.
Thank you. I hope everybody can see my screen, and thanks for the opportunity to come talk with you today. I'm going to be talking about the Boeing Company's Enterprise Threat Management Program.
I'm sorry, currently we don't see your screen. You have to hit share, the green button.
I got you there.
And then the blue button that says share. Perfect.
See it now?
Threat management at Boeing.
Yep, looks good.
All right, thanks. So the Boeing Company, some quick history on us. We have around 150,000 employees worldwide. We're in every state in the United States. We have offices in 71 countries around the world, and we have employees that are working in 134 countries around the world. So we have a very large global presence. And for Boeing, our threat management program, we picked, I've been involved in it for over 20 years, and I've been managing it with my partner, Christina Holbrook, for about the last 13 years. And we picked the word threat management as opposed to workplace violence because we feel threat management has a larger umbrella than just workplace violence. One of our mantras is when we're looking at our threat management cases is threatening behaviors. Threats and acts of violence is what our threat management team look at and what our threat management program covers. So it's just not someone who's acting out violently or has maybe made a communicated threat in a written or a verbal. It can be those threatening behaviors, the looks, the stalking, the following around, some of those things that don't exactly come out and speak that communicated threat or a written threat that causes concern. So we call our program threat management to cover a larger portion of that. And one of the key things for our threat management program and for any threat management program is your policy and having your company buy into it and agree with your policy and agree that this is an important program for your company to follow. So we have our policy Pro 1870. And that governs our threat management program, talks about our resources, talks about what's expected from managers, from employees, what the company will provide. One of the things we don't mention or don't reference is a zero tolerance policy. So we don't have that. We don't use that anywhere in our policy or in our training because every case is unique and different. Because every human being is unique and different. So you might have humans that are exhibiting some similar behaviors that you're dealing with, but each case will be handled different based on that particular human and their situations, the facts and circumstances around that case. And that makes it very unique. So having a zero tolerance policy locks you in to a position where you have to do something. So you were going to fire everybody who commits this act. And that really locks you into a bad position because what happens when you run into one of those situations and there's different factors, different things that play into this that could change why you might not fire somebody for that act. We have in our policy, we also let our employees know that we take this serious. These cases are investigated when it's reported and followed up on. We have threat management teams at all of our sites that deal with these cases. My next slide. So our threat management teams are made up of a multidisciplinary team of security and fire, corporate investigations, our human resources, employee wellness, the law department, health services, and our EAP program. These teams come together when a case comes up. They gather initial information, they meet as a team, they categorize what kind of case this is, and then they set forth their investigative strategy for investigating these allegations and what they're going to do with those. We also involve people from our communications department, our EEO, and our ethics, depending on what the circumstances of the cases and how we're going to go forward with that. Our threat management program is managed by our security organization. It falls under our CSO, Dave Commandant. And so he directs Christina, my partner, and myself. He directs us on what we do, provides us our support. And that's probably one of the biggest things for our program. And the success of our program is being able to have that backing from upper management that sees this as a valuable program and is there to help us when we need help in getting training rolled out or being able to come over some obstacles that we run into. Another important factor we have is training for our employees. We have mandatory threat management training for our employees. It started out, Christine and I started working on this in 2008, and finally in 2013, we got mandatory training for our managers rolled out. They have to take it every 3 years. Shortly after that, we were able to do mandatory training for our employees. And then 2 years ago, we took those two trainings, combined them into one. And so now we have one threat management training for all of our employees that they have to take every 3 years or when a new employee comes into the company. And the importance of that is being able for your employees to understand where their resources are, who they can turn to when they see these kind of behaviors, where they can report it, and having a number of different avenues for them to report it. An anonymous hotline through ethics, they can call the ethics hotline. They can report it through HR. They can report it by going to a security officer or to someone in security and reporting it that way. So there's a number of different avenues that they can report threat management situations at work. And then for our threat management teams, we do a yearly seminar for our teams. On a normal year, we do 5 seminars and we spread it out across the country to support our teams that way. And with everything that's going on this year, like this seminar, we'll be doing those online for our threat management teams. But it's very important to train them up on a yearly basis. Things change, policies change. There's different ways of handling situations that come up, and then being able to train them up and remind them on the foundation of our program, where our process flow is when they're working a case, the documentation, all that becomes very important for them in dealing with a case and making sure they're handling it right. And OSHA has a typology for workplace violence incidents, and they break it down by criminal intent, customer client, worker on worker, and personal relationships. So they're comparing a person to a suspect to a victim. What's that kind of comparison to it? In our program, we're looking at the behaviors that humans exhibit. And so we break it down a little different in the way that we describe that. So we look at abnormal behavior, assault, battery, communicated threats, domestic violence, homicide, possession of weapons, stalking, and suicide. So we break it down like that to help our teams to look at the behaviors more than at a typology that OSHA has broken out. And then when we're looking at the topic of the seminar, manage, reducing, preventing fear of violence. So when there's an active shooter event or a homicide that takes place in a community that's well publicized on the news, we'll tend to get questions from employees on what is the company doing to protect me? Why can't I bring my gun to work? Why can't I wear a bulletproof vest to work? Why don't we have a volunteer SWAT team to respond to these kind of things? So we see a number of these. So we've rolled out some training for our employees on active shooter, advanced threat, active assailant options, whatever you might call it. At Boeing, we call it an advanced threat incident because it could be someone who has more than just a gun. Maybe they have an edged weapon or a blunt instrument, and their goal is to injure as many people as they can. So we have a 30-minute training on our advanced threat program, and it starts off talking about our threat management program and behaviors, and then goes into our advanced threat, talks about what their options are if they're faced with that, with the get out, take out, hide out options. And then we have another training for them, our 201 training, which is a tabletop that we do in a staff meeting or a group setting where we talk about those different options and how you'd actually act those out. Most of us come to work in and out the same door every day, park pretty much in the same parking place. What happens if we can't go out our normal exit do we go out? Where do the other exits in that building lead? Where do they take you? So that training talks about that. And we see a lot of fear around those events that take place in the community that come back into work with those questions from employees. And then we're all in very unprecedented situation right now, driven by the COVID, people having to wear masks at work, having to social distance. We have a large portion of our employee base that's working from home, and they're trying to figure out how they're going to bring them back. And when we bring those people back into the workplace, they're going to be facing the mask issue, the social distancing issue, childcare issues. If their schools haven't opened and they're told they have to come back to work, how are they going to provide childcare for their children? And then the society issues that we see with the protests, some of the civil unrest that's going on, and the upcoming political elections. So we're in a year that I know I have never seen this kind of stress on people. I think we're all feeling it. And when you run into those people whose coping skills are very poor and their support systems aren't there, this is just kind of that ideal situation where they could act out and make some unwise choices. So there's a lot of fear that's driving those kind of things. And our program lets our managers know and our employees know that we focus on the behaviors of what individuals are exhibiting and dealing with those behaviors. And one of the statements in threat management is best prevention is early intervention. We tell our managers, when you see these behaviors going on, get involved with them early. Stop it, deal with it, address it. The longer they're allowed to continue, the more impact it has in the workplace, the more fear it can drive in the workplace. When employees see a coworker acting a certain way that's causing them fear and no one's addressing it, then they feel that fear is promoted by management, is accepted by management, and that causes a lot of issues. So getting involved in these situations early on and addressing those behaviors can help reduce the fear of the coworkers. And investigating the concerns that are brought forward to your company and making sure you're looking at them. And many times an employee will come forward and say, hey, this person said this and I see it as threatening. But you might not see that as threatening. So you have to take the time and look at it from the reporting party's perspective and ask them those questions. Help me understand, why is this threatening to you? Why does this cause you concern? What's the back history between these two employees? And you might find out exactly why that is. Maybe if it's a domestic violence situation, they mentioned, hey, he called me on the phone and he was playing this song in the background. It's like, okay, so what does that song mean to you? And that song is what was played when he would abuse her at home. And so he's making a call to intimidate her and he's playing the song in the background to refresh those memories for her for that. So being able to look at concerns that are brought to you and fears from the persons that's reporting it to you from their perspective does a great deal in being able to help understand that and help that person deal with the situations. And I'll stop there.
Great, thank you so much. Thank you to all of our panelists for such a broad set of experiences and insights. I really appreciate both the applied and theoretical approaches to this. So the first question I would like to throw out to the panel is focused on the news over time, but certainly a larger focus since the COVID outbreak that we're seeing in a lot of press on the proliferation of firearms. So I'm wondering if each of you could speak a little bit. We have healthcare, we have private business, we have law enforcement, and we have communities. How does this impact the work that you do, or how do you think that it will impact the work that you do, especially recognizing, as Megan said, that a lot of the motivation perhaps behind the proliferation of firearms is fear?
Do you want us to go, Dr. PCSA, in order?
Why don't you just go in order? So yeah, go Megan.
It's a great question. So it's something that a lot of us who work in the firearm injury sphere are talking about and trying to kind of figure out what to do with right now. To me, one of the biggest things and one of the underlying precepts underneath most of my work is community-based participatory research, but also community-based interventions. And so if we're talking about addressing the rise in firearm purchases and trying to decrease danger from those, it's about working with gun shops and gun owners to talk about why people are purchasing guns, how to improve training, how to improve safe storage. Dr. Betts and I have collaborated with the National Shooting Sports Foundation. We're working with 4-H in terms of training kids. I think that we have to acknowledge that this fear is driving purchase, and then we have to, as Dr. Bixler just said, we can't pretend that it's not happening. So we have to normalize the discussions of the fear and anxiety, and then create interventions that help to minimize those and help to make sure that people are trained as safely as possible. So that would be my kind of short answer as to the way to respond to it.
Great, thank you. David Mitchell? Whoops, Jay, we have you on, there we go.
Yes, thank you. Well, it's a concern. We saw what happened in Charlottesville when two opposing groups meet up. Now we're seeing, regardless of your politics, we're seeing people on the extreme left acquiring weapons, more weapons, and people on the extreme right acquiring more weapons. And whatever their motivation is, we're seeing with increasing frequency these weapons being carried to demonstrations. And I've got real concern, and my colleagues and I have real concern about this upcoming election, that there will be demonstrations no matter which way it goes. And with increased weaponry in the hands of people who have a short fuse, disaster is going to occur. Statistically, we know that suicides go up, that homeowners are more likely to get harmed by their own weapon accidentally than they are by an intruder or using it to stop an intruder from coming in to their homes. But looking at the media, and there's a lot of hype out there that, hey, we're coming for the suburbs. And you see, down south, the sheriffs are speaking up and they're saying essentially, get right with God before you try to get in my house because you're going to meet him, and so forth. So, from a law enforcement perspective, more guns aren't the answer, period. Of course, recognizing the Second Amendment guarantee, you want to have a gun in your own house, that's good for you. I do not oppose that whatsoever. What I do have great concerns about is heightened anxiety, heightened anger by people who are carrying locked and loaded weapons. Look at Michigan. In the State House itself, a guy screaming, within inches of a state trooper. Imagine he's got a weapon. He's ready to go.
Yes. Great. Yes. Thank
Scary
you.
stuff.
Yes. Now, how about John? Anything to add?
Yeah, so I want to give a larger framing. So you asked, I thought, in the context of COVID, and so in addition to being a professor, I'm one of the university vice provosts and the chief risk officer. I'm co-leading the university's response to COVID. So COVID is constantly on my mind, and I will say there's a bit of fear associated with it, but what I really want to focus on is uncertainty and loss of control, which I think are the triggers for fear in the context of the question. And with COVID, we have profound uncertainty, true uncertainty in so many ways that there is a true loss of control associated with that, a true loss of control because we're actually not empowered to the extent we should be, and so on. And what I think we're actually seeing in terms of the guns, I'm going to call it whack-a-mole. I think it's displaced seeking of control that is not directly associated with the things that the person is trying to control by the gun purchase. And so why did I talk about systems modeling? Well, first of all, because that's why I was invited, but I want to make a broader point, which is I think anytime you're talking about fear and fear of violence, it has to be contextualized more broadly. You have to look at a system. You guys know better than me, there's too many factors driving fear of violence because there's too many factors driving violence and there's too many factors driving fear to kind of zero in on one or two or three, these are the leading causes. And so I would simply say that particularly in the great example of COVID and gun purchases, contextualization is everything.
Excellent, thank you. And Dave?
Yeah, so I teach a personal safety training class at work and talk about guns. And, if you're faced with someone who pulls a gun on you and what's the percentage if you turn around and run? What's the percentage of them shooting at you? What's the percentage of them actually hitting you? And then if they do hit you with the bullet, what's the percentage of you dying from that or being a serious wound? And tell the people in my audience that I'm talking to that, if you carry a gun, you better be trained, you better know how to use it, and you better be willing to use it. Because if you find yourself in a situation where you pull that gun out and you're pointing it, say, at the bad guy, if you're not willing to use it, there's a large chance that bad guy is willing to take it from you and use it on you. So I mean, it is a very big issue in society. And I think we'd all be very shocked if we knew when you're out and about, say in a mall, how many people are actually armed. And how many of those people are legally armed with maybe a CCW and how many people aren't. So I think it's a very big issue in our country.
Great, thank you. So my next question is focused on how we move towards prevention. So throughout our 3 days, we've talked about fear and its relation to increased violence potentially, or its relationship with violence, but we've also talked about fear as a potential motivating factor. So in your broad conceptualization of fear of the unknown, lack of control, how can we use this moment to motivate more prevention activity? And I think I kind of liked it because you represent such amazing sectors. I mean, we'll go, I think, maybe backwards through and think about private sector, the academics, then think about law enforcement, and then we'll end with healthcare. So Dave Bixler, first to you.
It'd be great if we could figure out a model for dealing with a large population. But I think the way you have to deal with fears, you have to deal with it one person at a time, one issue at a time. Because so many different things drive fear in a person. What drives fear in me might not drive fear in you. So it's being able to take it one person at a time and try to deal with it that way.
I'm going to agree and disagree. So I think there are very specific interventions at the individual level that we need to think about. You asked about prevention, so I'm going to take that as a primary intervention strategy. So we think of that as building resistance through psychological inoculation. And so I think campaigns that are focused on building resistance or inoculating people at an individual level are important. But I also think there are interventions at a more community level that depend on the interdependence across people that are also critical. And so building social cohesion and framing programs that have people able to reliably rely on their neighbors is another important aspect of this.
Excellent. David Mitchell?
Well, we're certainly hoping that fear will help aid in compliance of CDC guidelines right now. We know, for example, here in Maryland, that we have flattened the curve. We have not eliminated COVID, but when you look at areas wherein the COVID guidelines are being ignored, we're seeing spikes. We're seeing ICU units maxed out. We're seeing thousands and thousands of deaths. You know, the bad information out there that, well, I'm young, so I can't get it. I'm of color, so we don't get COVID, and so forth. All this bad information is out there. And so I hope that fear acts as a motivator toward the invisible enemy that we're all facing here today. I can tell you that my troops have a good, healthy fear, and it causes them to take all the necessary precautions where we have to go the extra mile, decontaminating police cars before we go on patrol and so forth and whatnot, wearing a mask, and including our other PPE.
Okay, and Megan?
So I am going to try to actually synthesize what the other three panelists have said. So fear can certainly be a motivator. We know well, as an emergency physician, we talk all the time about teachable moments. And we know that in the emergency department, we can often use the teachable moment of an ED visit, that moment of fear about a potential diagnosis and the way that risk behaviors have intersected with that potential diagnosis in order to motivate, use motivational interventions, for instance, in order to motivate engagement in behavior change in a way that's not possible if you just approach someone on the street or even potentially in a primary care office. So there's certainly some role of fear and of a small low-level anxiety in motivating change. However, we also know from decades of health behavior research that fear and shame aren't, when kind of increased to a higher level, are not effective and can actually be counterproductive in terms of motivating behavior change. I think it's one of the big issues that we're caught in right now around the debate around firearm injury or gun violence, is that again, on both sides, we have descended into a discourse around fear and blame and shame. What I hear from a lot of my friends who are gun owners is that they are fearful of disclosing that they're gun owners, right? Because they're afraid of being stigmatized and called stupid. On the other side, you have folks who are not gun owners who hold that view of how can you be so dumb as to own a gun, right? And are so consumed by fear themselves that it stops them from going out and doing things and be working towards effective change rather than towards the extremes. I could make the same analogies around safe sex, right? And certainly we see it with COVID, where when we overemphasize fear, when we overemphasize stigmatizing people who don't meet public health regulations, that what we get is a pushback, and we get intransigence. And some of the best health behavior change is done by listening to those anxieties and fears and then developing ways in which it's easy and enjoyable for people to do the right thing, rather than focusing in on that fear, heightening it, and getting that kind of pushback or rebellious response. So I think there are numerous similarities between COVID and gun violence for a large variety of reasons. But to me, again, it's that balance of using the teeny bit of fear in order to motivate change, but not using that as the sole driver of how to get people to alter their behaviors.
Excellent. So one of the things that is really reassuring about this panel is that, you know, we get examples of some really great minds thinking about what can we really do. So we've had a couple questions come in on the question and answer blog that have focused on some specific examples. And it's nice because they've come in at some different levels. So I'm going to queue up two parts of a question. One is focused on brief intervention. So John got a little bit into primary prevention, but this question is very specific about brief interventions for frontline workers. And that might be managers, it might be healthcare providers, it might be law enforcement, but certainly many others. The next piece that we'll get to after we talk about sort of the individual frontline brief interventions is a question that came in thinking more about what specific examples are there to build resilience in communities before an event and then during and after an event. So first we'll start with the brief interventions, and I'll just let whomever is most motivated jump in first.
I'll take a stab. I'm gonna sort of riff on some stuff Megan said, because obviously she and I both come from a public health perspective. So I want to emphasize just a couple of things quickly. First of all, at the end of the day, it's really about behaviors, because functioning outwardly manifests as a behavior or set of behaviors. And what Megan said is that behaviors are driven really by two things: knowledge and attitudes and beliefs. And so in thinking about interventions whose outcome goal is a behavior change, you got to think about both knowledge and attitudes and beliefs. And so what I call education campaigns are often dismal failures because they only focus on the knowledge piece. The other thing I want to emphasize, because we're talking about fear, is fear as a motivator only works if there is a perceived self-efficacious response to the thing that's causing the fear. This is a really important point. If you have fear of something, and if in fact a physician, a public health professional has tried to convince you to be fearful so you take the threat seriously, yet has not delivered an intervention to manage the threat that you think, I can do that, and I can do that pretty readily, you're not going to try to manage the threat. You're going to try to manage the fear. And the way you're going to do that is to dismiss the threat. So fear as a motivator only works when it goes hand in hand with a perception of a self-efficacious intervention.
So I'm going to just riff off of that really quickly if I can. I could not agree more strongly with everything that John just said. And I'm going to add on to that another part where you specifically asked about those brief interventions. And we have so much evidence that those brief interventions work in certain contexts. It can't be people too far on either side of the spectrum, right? We think about kind of the analogy of alcohol interventions. If someone has severe alcohol use disorder, is a daily liter-a-day drinker, a brief intervention is not what they need. Ditto, if someone is they drink 2 times a week, a brief intervention is not what they need. It's those folks who are in the middle of the risk spectrum who need a brief intervention. There's also increasing evidence for us around the realm of violence prevention that a brief intervention, and I know there's a lot of debate about boosters out there, but that brief intervention specifically for these complex cognitive and behavioral conditions, of which violence is one of them. A brief intervention can help motivate, it can help increase self-efficacy, can engage them, but that it often needs to be followed up with a more longitudinal course, either repeated boosters, some sort of additional information, reminders of self-efficacy, behavior change interventions. So brief interventions have a role, but for a certain population and often in conjunction with other things over kind of a longer period of time.
Great. Yeah, and so I have to apologize that David Mitchell had to sign off for another emergency COVID meeting. So I'm sorry we lost his insights into this discussion. But Dave Bixler, I think one could argue that the training you have that's now enterprise-wide is an intervention, a brief intervention. I don't think it has to be argued. And there was a question that came up about how do you help managers know when to call for help? And I think that's an important answer, because in thinking through how that works in your business, it probably applies to how many of us have to think about that. At what point is it that we think we need to act on this?
Yeah, so we've got managers who might have 15 to 30 employees that they manage on a daily basis. And so them staying engaged and knowing those employees can become very difficult. And then them, many times it depends on the person, but them being able to step in and deal with a situation, like I mentioned, early intervention. Some managers don't have the best skills for that. And some of them look for that help, and we try to help them through our EAP and being able to deal with difficult conversations with people to try to overcome that. Some of them do a better job, some of them don't, and hopefully through our training, they see the options and the resources they can go to if they lack those skills or they need help. And I think that's an important thing that John was talking about, was having that fear, using that as a motivator, but also you have to have those options for that fear for that person to deal with it. How can they deal with that fear? How can they take that and motivate them, or use that as a motivator to get out of that position, or to take some type of action that's going to help themselves.
Excellent. Okay, so let's move to the next layer of this, which was some specific examples the questioner had asked about community resilience building, and the primary is in our context of public health. What do we do before something happens? What do we do when something is happening? And what can we do in the aftermath?
So I'll jump in and take a stab at this. First of all, I personally think it's all about what you do ahead of time. The fact of the matter is response and recovery depend on prevention and preparedness. And because even the things you do during the response phase, you should have completely planned out and staged ahead of time. So I'm just going to give one example. So we're doing a lot of work with New York City, and they've built a program called Be a Buddy. It happens to be a specific focus on heat-related events, but that's irrelevant to why I'm bringing it up. It's really about building social cohesion by building informal social networks that in times of, I'm going to say, trauma, give you a network to turn to that is physically and socially immediate in a way that formal city agencies never feel like they are, and in a way, frankly, that community-based and even faith-based organizations at times don't feel like they are. And so, but when would you build that intervention? Flat out ahead of time. And the fact of the matter is there are very few interventions that occur during the response phase that have organically arisen without planning and staging during the response phase. So everything's about what you do ahead of time.
Anyone else want to add to that?
Yeah, I think another good example of that is a few years back I worked with a city here in Southern California and putting together a threat management plan. The cities were going through some layoffs. A neighboring city had an employee who had committed suicide, jumped out of the city hall building when he was given his layoff notice. So that caused a lot of fear and panic in this city. What can we do about that? So we put together some threat management training for them. They were all excited about it. We were going to present it at their next city council meeting. It got delayed because they needed to talk about budget issues, and it got delayed again. And the further away we got from that event, the less important it became to that city and basically dropped off. So planning for this kind of stuff is very important. I don't think you can do enough planning for the different situations you look at. And in many times in cities or in companies, they take they take the approach that this isn't going to happen here. This can't happen to us. And so they don't plan for it. They don't even think about what would they do if this happens. And then when they find themselves in that situation, they're lost and they're way behind trying to catch up and mitigate the problem out.
That said, as an emergency physician, I am the queen of secondary and tertiary prevention. I rarely get the chance to do primary. So although I agree that ideally you create community resilience ahead of time, and although John's work and Dave's work have identified some of those factors that can help increase resilience before something bad happens, I don't think we should throw up our hands and give up just because a community is already affected by violence. Mm-hmm. And there have been some great studies showing that there are ways to increase resilience within communities in the context of disasters having already happened, either natural disasters, terrorist, and or day-to-day community violence. One of the studies that I love to cite is work done by Charlie Brannis, who's now at Columbia, and by Gina South, who's at Penn, looking at environmental modifications and how those decrease violence, as well as decrease anxiety, depression, and PTSD among communities with high rates of community violence when you kind of green vacant lots and do other environmental interventions. There are also other studies, such as after the Boston Marathon bombings, looking at kind of, as John mentioned, but looking at changes in kind of social media use, media consumption, et cetera. And then, as you mentioned, kind of the faith-based groups, creating community support. There's certainly, this is an area that we need more research on, but I don't want us to feel that we can't do anything after the fact. I think it's an area where there's a lot more to be done. And unfortunately, right now, we're in a situation where an awful lot of communities across the United States have been affected either by watching something, right, that affected the kind of quote unquote mainstream media, but like kind of typical TV media and or social media, or have experienced it within their communities themselves. And there's still work that can be done to help healing and to prevent future episodes of violence.
So just two quick additions to what Megan said. So again, thinking about systems thinking and modeling the whole system, one of the advantages is on a community by community basis, you can identify the strengths and weaknesses, and they're going to be different. So it's sort of different parts of the system are more worthy or less worthy of intervention from community to community. And when you think about that systems model, however you would draw it out, there's going to be a baseline piece, and then a piece having to do with during the trauma, and a piece having to do with recovery from the trauma. And you ought to be paying attention to wherever the weakest components or elements are in that entire system. The other thing I want to note is the time after one traumatic event is also the time before the next traumatic event. So the experience that an individual, an organization, or a community has with trauma means that they're recovering from a past trauma, but that state is pre-event in the context of the next trauma. And so how you deal with that individual or organization or community should be considered from both angles. And the positioning for the next trauma, I had a line at the end about experience being both positive and negative. So it's positive in terms of at least a couple of ways. It's motivating, as we talked about a few minutes ago. Also, at times, familiarity itself helps deal with fear and makes the room for more cognitive interventions that actually position the individual or the community better for the next time. It's negative when it sensitizes the individual or the community. That is, it can actually, of course, just think of it like an anergetic response in a biological sense, sensitizes so that there's a more profound negative reaction triggered by fear the next time. And so understanding the positive and negative influences of experience are critical at both an individual and a community level.
Great. Well, we are at time. There are so many good questions that have come in through the chat boxes that I wish we had another hour to chew through more of this. But unfortunately, we must draw to a close. So now in the last couple minutes, Emmy and I will try to wrap up. I think the most important thing we need to say is thank you for 3 days of amazing insights, people who have been so generous with their thoughts and their expertise, and have helped us really get to a place that we have a whole lot to think about. You know, both feeling good that there is such a growing knowledge base, but then we have so much work to do on so many fronts. So Emmy, do you want to say a few words?
Yeah, wonderful. It's so hard to think about how to try to sum up any of this. I've been thinking, especially today, thinking back, and when we started planning this workshop really over a year ago, which was long before any of us had heard of COVID, and really before the most recent wave of protests related to race and policing had begun. And it feels like the landscape has changed. And I am so grateful that we were able to continue the movement of moving forward and planning this workshop, but also try to adapt to bring in some of those newer or unfortunately recurring themes. But even back when we started, we knew we'd pick a really big, tough topic. I think as a lot of panelists have brought up over the past 3 days, what is fear of violence? Do victims or survivors, or the different terms we use, do victims themselves feel afraid? Or actually is not being afraid part of the resilience that we want to build in people? And, I think certainly the topic was hard when we started, and it's become more difficult. And so I'm so grateful we've been able to touch on a broad range of issues. But I also acknowledge we have not had the time or space to go deeply enough on probably many of them. We very easily, I think, could have had a whole workshop on race and violence, or on gender-based violence, on firearm injury prevention, on policing, on really any of the small, the sessions that we had. And so as co-chair and someone from the planning committee, if you are left unsatisfied on some topics, I apologize. But I really hope, you know, for me, and I hope that for the audience as well, I think that thinking broadly across issues allows new connections and new models and hopefully new approaches for the future. As we've thought about sort of common threads, the heterogeneity of different populations and different issues related to violence and fear of violence, but at the same time, some of the common approaches perhaps that we can really learn from each other. I think as some panelists have made the point about how critical it is for us to recognize each other's humanity and each other's own experiences, including experiences of trauma, and thinking about how we need to talk and we need to listen, we need to get out of our silos. I think all of us who have been here the past few days have the privilege of being here, and personally, I really think the responsibility of doing what we can to try to make our world a safer, better place with less violence. And I firmly believe we can do it with both science and compassion. So I just thank you again to the audience, to the panelists, to the forum members for your engagement and for the opportunity for me to be involved in this forum. And I will end there and turn it back over to Corey.
Thank you, Emmy. Those are some wonderful wrap-up thoughts. I think one I'm left with in moving forward, one thing that was absolutely confirmed by every one of our speakers, taken in sum, is how many different areas of expertise, how many ways we can think about this, how many different communities need to be at the table. So at a time when all of our worlds have more uncertainty in them, and probably to many of us that has added a level of busyness and conflict between our personal lives, our work lives, our needs for ourselves, and those to take care of our loved ones. We absolutely need to be mindful and take the time to move into this work and our next work, bringing people together and bringing more voices to the table and challenging ourselves to bring new voices that we haven't worked with in the past. And so hopefully this has also been somewhat of a networking experience. It's a little harder to do that virtually, but hopefully in the future, everyone will talk to at least someone who they learned something from somehow from this experience. So I do want to make sure everyone still attending knows that a proceedings in brief of the workshop, as well as recordings from the workshop, will be made available to the public. It will be through the Health and Medicine Division of the National Academies. If you have any questions, you can contact Lisa Hamilton, our wonderful organizer. And I want to end by saying a huge thank you again to everyone who stuck with all of this, who attended parts of it, to our forum, to our planning committee, and to Lisa, who put so much energy and thought and diligence and planning into our ability to be together for these past 3 days. So with that, I will say thank you and hope everyone has a beautiful rest of your afternoon.